Yeah. Dr. Satish is our chief cardiac surgeon, and he got the golden opportunity of performing more than 11,000 cardiac surgeries as a single-handed surgeon. And probably one of the few surgeons probably in India who got that experience of doing more than 11,000 surgeries and single-handed. And recently he joined one more cardiac surgeon also joined in the team. And we are working as a team from the last 20 years. Thank you. And aim of the present conference is, in the present era of advanced structural heart interventions like TAVRs, while people are talking about the TAVRs, transmitral percutaneous mitral valve replacement, Racus valve replacements, we are a bit embarrassed to conduct a workshop on a primitive procedure which was started in India in early 90s. And somehow, after taking an initiative and asking people and seeing the response, there was a huge response from many of the junior colleagues showing interest to learn PBMVs. Because probably nowadays the cases are coming down, opportunities are coming down, and many people are not getting an opportunity to even visualize PBMVs. That gross difference we are noticing distinctly, because the earlier generations when we are trained, we used to have a lot of exposure to PBMVs, and of late, to be frank, I stopped doing PBMVs from the last 10 years, because many of my junior colleagues are handling those cases. And we, especially in the KIMS, we are doing a huge number of PBMs since many years, and not to the extent of Professor Dash, where I was surprised to see he performed more than 20,000 valvuloplasties from Puttaparthi and Bangalore and at present from Orissa. We on an average perform more than 100 valvuloplasties per year, and so far we crossed nearly 2,000 valvuloplasties here. So with this huge volume, probably we thought probably it's a responsibility to share our experience and expertise to the junior colleagues. So we took this initiative to start this program. And welcome to the faculty. And here we have the senior Dr. Professor P.K. Dash. He is the Director and Professor of Cardiology, PJMRC, Capital Hospital, Bhubaneswar. And actually he was very busy, his dates were not available. But when we requested him, initially he said no. But a man having a passion for PBMVs, immediately second day he said, I am cancelling all the programs, and he said to spare his 2 days of time here to share his experience and to train the junior faculty. Really, it's a great privilege, sir, and we are honored to be here with you. And Dr. Raghu, he is a senior faculty, and now he is a senior faculty in Yashoda Hospital, Secunderabad, a great academician, teacher. And really, it was glad for having Dr. Raghu here for this program. And Dr. T.N.C. Padmanabhan, he is a senior interventional cardiologist in KIMS group of hospitals. And to be frank, he is the person who taught us to do PBMVs. Even in NIMS, even in the early part of the hospital in Rajahmundry, he used to come and do PBMVs, and he taught us how to do the PBMVs. And we are very much thankful to you, sir. And after a long time, we could get you here to do the procedures. Thank you. And he is Dr. Professor B. Srinivas. He is my friend. He is now in HOD cardiology. He is coming on the way. He will be the part of the program. Jain, sir. Dr. P.V.N.M. Kumar, my friend, he is a senior interventional cardiologist from CARE Hospitals, having very much a passion for echocardiograms, interventions, and he is going to train us with for 3D imaging of mitral valve disease, which we really, even we don't have any exposure and experience to for 3D echocardiogram. I think we'll learn a lot of points from him through this. And over and above, it's a rare opportunity to invite Dr. R.K. Jain, because he's a national faculty, and he is a head of all the cardiology departments of entire KIMS group of hospitals. because whatever the new introduction, he is a very dynamic person, as you all know. Any new technique, any new procedure that has to be done, he will be the first person to learn, and he is a pioneer in many of the structural interventions nowadays, and he is doing a very, very good work, and he is an inspiration to all our generation. He is a teacher for us in NIMS, and as well as he is an inspiration for many of us, and even for the coming generations. We should learn a lot of things from him, and really thank you, sir, for being here. And next faculty is Dr. Sujata. Sujata, she will be attending tomorrow. She is one of my friends. She is a senior interventional cardiologist in KIMS group of hospitals, Indus Hospitals. Sorry. So we took all the, we selected the cases. We made 30 cases available here for PBMVs, and we made arrangements for 9 cases to be done as live cases for today and tomorrow by the senior operators, and we have given another 21 cases for the hands-on experience for the juniors under the supervision of these senior operators. And we have taken all the precautions to display a wide variety of mitral valve variants from the PBM, right from straightforward PBMs to a calcific single commissures, dense subvalvular aortas, giant LA, dilated RARV, some tricuspid valve disease. Like that, we try to arrange different spectrum of cases, and hopefully we hope that we will cover the entire spectrum of mitral valve disease, which are amenable to mitral valvuloplasty. And juniors faculty were given allotted time for the hands-on experience, and we request only the designated delegates who are given for the cath lab experience to be there in the cath lab, and rest to be present in the hall to share, to listen the experiences from the senior operators, and as well as to listen to the live interaction. And hopefully, I think these 2 days session will bring you a confidence in performing the procedures. In your near future, probably it will be helpful. And if this 2 days workshop is successful, we are planning to conduct this program every year, at least to share the experience of PBMs and train the junior faculty for PBMs. Thank you. టాక్ పెట్టేసి తర్వాత మీ మీద క్యాత్ ల్యాబ్ లైవ్ కేసు లైవ్ కేసు
ఫస్ట్ టాక్ అది పెట్టాలండి. రేవంత్ సార్, రేవంత్ సార్.
వీళ్ళు ఉన్నారా అదే as per the plan is concerned, we have 2 cath labs, one in the cellar area and one in the ground floor area. Cellar area cath lab is used for live transmissions, and hands-on training is done for the hands-on experience. And changing rooms are arranged in the ground floor at room number 108, and whoever is going to the cath lab, they can change their dresses and go to the cath lab in the ground floor area. In the cellar area, we have a live transmission cath lab, and first case we will start around 11 o'clock by Professor P.K. Dash, and people who are Dr. Faniteja and Dr. D.P. Kalyan Chakravarti from KIMS. If he is there, he can join Professor Dash to do the program. And first hands-on case will be done by Dr. T.N.C. Padmanabhan and Dr. Chakradhar from Apollo Vizag, and Rakesh from Indus Hospital. If he is there, he will join Dr. Padmanabhan to learn the tips and tricks through him as a first case. It will be done in the cath lab 1 in the ground floor area. So after this talk, we
So now we'll first start our first talk. Okay. అది స్టార్ట్ చేయరా PowerPoint. Now the first topic is PBMV indications and contraindications by Dr. V. Ravant.
Good morning, all the delegates and teachers. Now we will be going around the indications and contraindications for PBMV. The first percutaneous mitral commissurotomy was published by Enoy and co-workers in 1987. And the PMC acts by opening the fused commissures and is of little or no help in case of restricted valvular mobility caused by valve fibrosis or severe subvalvular disease. And the patient selection is very much important for PBMV. And the selection of patient involves the consideration of clinical profile and valve morphology. And Wilkins score is used in which a total score under 8 is considered favorable anatomy for PMC. And the Wilkins score consists of 4 components, which includes mobility, thickening, calcification, and subvalvular thickening. So depending upon the grading, it was divided. The points were given as 1, 2, 3, and 4. So total of 16. And a score which is less than 8 is amenable for PMC. And a mitral valve with a score less than 8 or with no more than moderate MR is deemed to be the best candidate for PMV. In patients with score more than 9 to 10, especially with more than moderate mitral regurgitation, indicates surgical therapy should be advised. And a limitation of scoring system is the lack of information on the location of the valve abnormalities in relation to commissures, which may influence the results of PMV. And coming to the selection of optimal candidates for PMV, the age should be less than 45 years and should be in sinus rhythm with Wilkins scores less than 8 and with no history of previous surgical commissurotomy and pre-MV MR less than or equal to +1 SELA grading. And so AHI ACC divide the MS into 4 stages, stage A, B, C and D, in which depending upon the valve anatomy, valve hemodynamics and hemodynamic consequences and symptoms, stage A is at risk for MS, and stage B is progressive MS, and stage C is asymptomatic severe MS, and stage D is symptomatic severe MS. And the mean gradients were not included here because of a change in the variability of mean gradients with heart rates and forward flow. And the indications for PBMV are in symptomatic patients, symptomatic severe MS with NYHA class 2, 3 or 4 and with mitral valve area less than 1.5 centimeter square and favorable valve morphology with less than moderate 2 plus MR. And in severely symptomatic patients with unfavorable valve, surgical intervention should be advised. So in asymptomatic patients with severe rheumatic MS with valve area less than 1.5 centimeter square and favorable valve morphology with less than 2 plus MR in the absence of LA thrombus who have elevated pulmonary pressures with pulmonary artery systolic pressures more than 55 mm Hg, PBMV is reasonable if it can be performed in a comprehensive wall center. It's a class 2A indication. In asymptomatic patients with severe rheumatic MS and favorable wall morphology with less than 2 plus MR, in the absence of LA thrombus who have new onset of AF, PBMV may be considered if can be performed at a comprehensive wall center. It's a class 2B indication. And in symptomatic patients with rheumatic MS and an initial wall area more than mitral wall area more than 1.5 centimeter square, if there is evidence of hemodynamically significant rheumatic MS on the basis of pulmonary artery wedge pressure more than 25 mmHg or mean mitral wall gradients of more than 15 mmHg during exercise, PMV may be considered if it can perform at the comprehensive heart center, and it is a class 2B indication. And in severely symptomatic patients with severe rheumatic MS who have a suboptimal valve anatomy who are not candidates for surgery, so it is indicated as 2B indication for PMV. And these are the ESA recommendations. And coming to the intervention, the rheumatic mitral stenosis with severe MS less than 1.5 centimeter square, and if it is symptomatic stage D and the valve is amenable for PMV, we can go ahead with PMV, it's class 1 indication. And if the valve is not amenable for PMV, then surgical intervention should be opted. And in asymptomatic patients in stage C, and if the presence of pliable valve and no clot, and if the pulmonary systolic pressure is more than 50, PMV is indicated with the class 2 indication. And in the same patient, if it is a new onset AF, the PMC indicated, it's a class 2B indication. And the controversies about indication for PMV exist in these cases. Is that asymptomatic moderate MS, moderate to severe MS, and symptomatic mild and symptomatic severe MS with unfavorable anatomic characteristics. And in asymptomatic moderate to severe MS, both guidelines advocate that early use of PMV should be considered for patients with high risk of embolism who are having paroxysmal AF and history of embolism or evidence of spontaneous echo contrast and new onset paroxysmal atrial fibrillation or hemodynamic decompensation. And if patients complain of dyspnea on exertion that is out of proportion to the degree of MS, the ACC guidelines recommend use of excess Doppler echocardiography to reveal occult hemodynamic significantly MS. And this is the class 1 indication for hemodynamic assessment. And coming to the contraindication of PBMV, persistent left atrial or left atrial appendage thrombus, more than moderate mitral regurgitation, and massive or biconventional calcification, and severe organic stenosis of severe functional regurgitation with enlarged annulus and severe concomitant coronary artery disease, then we should advise for surgery. Thank you.
Thank you, sir. Now I'll invite Dr. C. Raghu, sir, for the next topic, role of echo in PBMV.
I think good morning everyone. It's heartening to see Dr. Ramaraju and KIMS Hospital to conduct this program on PBMV. Worldwide, the numbers of balloon mitral valvotomy are reducing, and it is no exception in our country also. There are a lot of pockets where the incidence and prevalence of rheumatic heart disease has been continuously declining. So what are the implications of that? First is the fellows and the cardiologists who are entering into the practice do not get a opportunity to get trained on the balloon valvotomy. That's the number one. So I think that is the main objective which Dr. Ramaraju has envisaged this program. The second issue is globally with the reduction of rheumatic heart disease rates, It's playing. The problem is every year there is a reduction of rheumatic heart disease by about 8 to 10% in the United States, and the complications of balloon mitral valvotomy are increasing by 15%. So, if one is not trained well, because there is no enough cases, the complication rates are increasing. So, that is another major challenge. So, that leads to a knowledge gap, and that knowledge gap is getting translated into a worse outcomes to the patient. And that is why if you see in the latest guidelines also, they have introduced a term called as the CVC, the Comprehensive Valve Center, to perform the balloon mitral valvotomy. From the days where balloon mitral valvotomy was a regular procedure, it has become a quite specialized procedure in the developed countries. So, Dr. Ramaraju's center and KIMS have become a leader in this balloon mitral valvotomy because they do a large number of cases. So, when they asked us to present it, I thought it would be a good opportunity to share. I am not an expert because when we stay in Hyderabad and all, our expertise in balloon mitral valvotomy is not so good compared to what Dr. Ramaraju and others can do in these centers. So, this today the major challenge what we encounter is the etiology of mitral stenosis has to be deciphered by echocardiography, because there is a demographic shift in the cause of the mitral stenosis from a predominantly rheumatic to a sclerodegenerative or a degenerative mitral valve disease. So, it is imperative upon us to choose the right case. So, echocardiography plays an important role, and I think that is the only test based upon which we can find out the etiology to select the right cases. Balloon mitral valvotomy is a procedure to be performed for rheumatic mitral valve disease. That is the first point I want to emphasize upon, because as we go forward we can discuss that. Then the severity assessment. Previously we used to have a cutoff points which were different from what we are practicing now. At the American College of Cardiology and the European Society have given a cutoff point of 1.5 square centimeter compared to 1.0 which used to be there for a severe or a very severe mitral stenosis. Nowadays, people who have got a mitral valve area of less than 1.5 square centimeter as a severe mitral stenosis, and that needs to be addressed upon. Then some degree about the scores for the valvotomy, and we understand that no one score is perfect for the valvotomy. Then how do we define a successful valvotomy? And for example, post procedure, if a patient develops a mitral regurgitation, is it going to be a favorable mitral regurgitation or an unfavorable mitral regurgitation? Finally, contraindication to valvotomy and complications of mitral regurgitation. So, this would be the next slide. So, next we go forward. This would be the go forward, please. Forward. Yeah, let's stay here. So, this is the classical predominant features we all know, because all of us are cardiologists, and it is like the thickening, mobility, subvalvular fusion, commissural fusion, calcification. These are the predominant features what we need to look in the mitral valve on echocardiography. Next, please. So, there are lot of these terms are used in our routine day-to-day practice, but there are definite criteria to objectively define each of these parameters. But the challenge is to remember these numbers is so difficult. I tried to give you a short synopsis of each of these features. For example, valve thickening. About less than 2 is mild, and 2 to 5 is moderate, and more than 5 is severe. And how do you assess the valve thickening? We can compare this is the ratio. So, the ratio is we compare the thickness of the mitral leaflet with the posterior aortic wall in the parasternal long axis view. So, it is not the absolute number of the mitral valve thickness, but it is a ratio between the mitral wall leaflet thickness versus the aortic posterior wall. So this we need to estimate in the parasternal long axis view. Next, please. Now, as I told you in the first point, whenever we look at the mitral stenosis, because nowadays we see lot of elderly patients coming to us with mitral stenosis or mitral regurg stenosis combination, many of them are labeled as rheumatic mitral stenosis, which in fact might not be true for all of them. So we need to look at the commissures. And here I have given three major points based upon which you can differentiate the rheumatic from the degenerative valve. So the degenerative valve is quite a common problem in women who have got atrial fibrillation or paroxysmal atrial fibrillation, background history of hypertension, other cardiovascular, atherosclerotic cardiovascular risk factors being present. Most of them have got a background of heart failure with preserved ejection fraction. So this group of patients, they have a calcium at from the annulus and extending on to the leaflets. On the contrary, if you have got a rheumatic valve, the calcium is predominantly in the leaflets and in the commissures. The major difference is the commissures are fused in rheumatic valve, whereas in a degenerative valve, they are usually free. This is a very important feature we need to look on the echocardiography. The leaflet mobility is restricted in rheumatic disease. That gives the classical doming and the concavity of the mitral leaflet during diastole, whereas tips of the leaflets are usually free, but sometimes they can be restricted because of underlying left ventricular dysfunction. So you have to differentiate a rheumatic from a degenerative, because if we want to perform a mitral valvotomy, it has to be done on a rheumatic valve. Next, please. So I just tried to show these features. What you need to look at is this first panel, where you can see the classical doming of the anterior mitral leaflet with the concavity towards the left atrium. That indicate that it is a non-degenerative. It's a classical of a rheumatic or a congenital. Whereas on the leftmost panel, you can see that that classical doming is not seen in a degenerative mitral stenosis. The commissures are usually fused, the medial and the lateral commissure. The commissures are usually free in a degenerative disease. So these are the two important points to differentiate a rheumatic from a degenerative mitral valve disease. Next, please. Now, so we can assess the valve mobility also. So for that also there is an objective scoring system, but I think this is also there theoretically, but I'm sure we will not be able to practice on a routine day to day, but only as a reference point. So we have objective ways to assess the thickening, objective ways to assess the valve mobility. Next, please. Another important point what we need to look at is at the subvalvular pathology. In a rheumatic valve, subvalvular pathology is pathognomonic, whereas in a degenerative valve, subvalvular pathology is not so a very important feature. So rheumatic pathology affects the whole of the mitral valve apparatus. The other thing is, we have to identify the subvalvular pathology. All of us know various views, 4-chamber, 3-chamber, we evaluate the subvalvular pathology. When I do any echocardiographic assessment, which everyone who does a balloon valvotomy should look at the valve himself only, not depend upon a colleague for assessment of the mitral valve, because the echocardiography has to be performed by the operator so that they know, especially in our setting, not in the Western world, but in our setting we need to do the echocardiography ourselves. The subvalvular pathology, so whenever we do the echocardiography, so we determine the severity of the subvalvular pathology. In addition, I always look at where the turbulence and the gradient. So we can do a pulse wave Doppler and assess, apart from the valvular level, is there any subvalvular mitral stenosis also in the subvalvular level also. So that has got a significant impact on the BMV result. And based upon the shortening of the chordal shortening, if the chordal length is less than 10 millimeter, then you can say that the subvalvular apparatus is severely diseased. So why we need to look at for the subvalvular in the multiple projections? It has got a tremendous impact when you look at the final outcome. You do a significant valvular reduction, and sometimes it can have a adverse outcome because of the mitral regurg also. Next please. Then calcification. We will show some pictures. I am sure Dr. Kumar also will show on echocardiography the presence of calcium in mitral wall. So we all know that how to look for calcium. They appear as bright echogenic spots on the leaflets. Now the calcium at the commissure level. So one of our seniors, Dr. C.V. Rao, has done his thesis research on the commissural morphology for balloon valvotomy. So over the years, like Dr. Padmanabhan, Dr. Rajendra, Dr. C.V. Rao, we all learnt our balloon valvotomy from them. So the presence of calcium over the commissures is an absolute contraindication. For example, sometimes good operators like from the Dr. Ramaraju team might be able to do if there is calcium on one commissure, but if it is on both the commissures, it is a challenge for them to perform, and this one. And if there is a calcium on the leaflet body, it is not a contraindication. So when we perform the echo in the parasternal short axis, we need to differentiate where is the location of the calcium, whether it is in the commissures or on the body. If we are fortunate enough, if we have got a 3D echo, the 3D echo shows the calcium much more clearly and the commissural morphology in a very lucid way. Next please. Wilkins score, my previous speaker has already alluded to. Next please. And there are this Cormier score also. Basically this focuses on the subvalvular disease and the fluoroscopic calcium. If you see here the group 3, the calcification of mitral valve on the fluoroscopy is indicates that this patient is not a good candidate for balloon valvotomy. So long ago, when I was at Alnia Institute, we used to look at the fluoroscopic mitral valve calcium, and based on that we used to determine whether the person is amenable for valvotomy or not. So fluoroscopic calcium is one more parameter to estimate whether the patient is suitable for valvotomy or not. Next please. This is the major change compared to the past to the current era in the 2020 guidelines, and previously in 2014 guidelines also. It has been shown that the mitral valve area less than 1.5 is severe and it is associated with pulmonary arterial hypertension. So it is a true multi-parametric. We should not look at only the valve area, we should look at pressure half time, we should look at pulmonary arterial systolic pressure, we should look at the left atrial enlargement. So based upon all the various parameters, we have to estimate the severity, not just based upon the valve area. We would say that this patient has got severe MS or less severe MS. So this is important, for example, in patients who have got a multivalvular disease or patients who have got a mitral regurg plus mitral stenosis. So in those circumstances, this staging and the role of pressure half time is very important. Next please. Now assessment of the severity of mitral stenosis, we all know how to assess the severity. Next please. I would focus upon the important points. For example, assessment of severity is done by Doppler, echo, 2D echo, and novel modalities also. And the new guidelines say what we call as the level 1 measurement recommendation, level 2 recommendation, level 3 recommendation. So for people where there is a internal inconsistency, we have to do a level 2, proceed to the level 2 recommendation. If you have got still a inconsistency in these findings, then we have to go to the level 3 recommendations. So planimetry is a very important parameter for us to see on 2D echo. We have to set the grayscale to the lowest gains so that we get the right mitral valve area. Inner contour of the mitral valve has to be planimetered and commissures have to be included. And in patients of atrial fibrillation, as we know, we need to take multiple measurements. Next, please. Next. Then mitral valve leaflet separation index. Lot of my younger colleagues do rely upon this parameter, but I rarely use that, and there are cutoff points given for the leaflet separation in the apical 4-chamber view. Next, please. Then mitral gradients. We need to understand that if we are going to assess the severity of mitral stenosis based upon the gradient, we need to look at the mean pressure gradient. And it is very important, actually the AAC guideline says that we need to document the heart rate on all echocardiographic reports. So we need to measure the pressure gradient at what heart rate. That is important. In a patient with tachycardia, you can have a spuriously elevated gradient. Pressure half time is an important parameter. That is why the latest guidelines say pressure half time more than the mean pressure gradient. But it has got its own limitations when there is left ventricular hypertrophy or aortic regurgitation. Next, please. Then there is a possibility, this is a level 2 recommendation. For example, if you have got an incongruity, you can estimate the mitral valve area either by continuity equation or by the PISA method. Both these things are quite simple. In my cath lab, the lab technicians do the continuity equation and PISA also. Next, please. Next, please. Now, what are the other broad things? If the left atrial size is less than 5, the patient will have a good outcome. More than 6, it is a giant or an aneurysmal LA, the outcomes are not so good. We need to look at the spontaneous echo contrast. All of us know that, and we need to document in the report because that has got increased thromboembolic event potential. Left atrial thrombus, we will discuss it further. Next, please. So, Dr. Manjunath, who is a pioneer of balloon mitral valvotomy in our country, has classified the thrombi and graded them into 1 to 5 grades. What is important for us is anything up to 2A, it is balloon mitral valvotomy can be performed. That means the thrombus is limited to the left atrial appendage, or thrombus is attached to the left atrial roof, but not entering into the left atrial chamber. Going on from 2B to 5, we cannot perform. They are absolute contraindication for a balloon mitral valvotomy. Next, please. Now, interatrial septum, we have to look at the presence of foramen ovale or an ASD, and similar to that of a left atrial appendage device, we need to look at the presence of aneurysm, whether how is the bulging septum, and if the septum is bulging towards the right atrium, thus we might encounter some challenges in the septal puncture. And the presence of any thrombus on the atrial septum is an absolute contraindication. Next, please. Then mitral regurgitation. This we will discuss in little greater detail, because presence of central mitral regurgitation is not a contraindication for mitral valvotomy. But if the patient has got an eccentric mitral regurg or a regurg of 3 or 4 MR, that is more than mild MR, then we consider it to be a contraindication for balloon mitral valvotomy. There are certain parameters which have been proposed by various scorings to differentiate, to predict which patient can develop MR pre-procedure. But what we need to understand is, if there is a commissural calcium, if there is a severe subvalvular disease, if there is a uneven thickening of the mitral valve leaflets, these are the groups of patients who can potentially develop mitral regurgitation post-procedure. Next, please. What is the importance of mitral regurg after balloon valvotomy? So, there are some new data which are coming on this. I will share this data. So an increase in the severity of the mitral regurg is relatively common, and it is mainly due to the splitting of the commissures, and it is usually associated with a favorable outcome. So MR post BMV is usually transient, or it lasts for a few days, and it is associated with a good outcome if the MR is through the commissures and if it is a central jet. Whereas if there is a tear of the central scallop or in the subvalvular apparatus, they require an immediate surgery. So patients post procedure MR echocardiography plays a lot of role. I will show you some representative images from the JAC article, recent ones. Next please. Now, as we all know, the anterior mitral leaflet has got A1, A2, A3, posterior leaflet has got P2, P1, P2, P3. And based upon the development of the mitral regurgitation in this group of around 130 patients, they differentiated into 4 groups. If the patient has got a central mitral regurgitation, usually this patient do well. And if there is a commissural MR, they also do well. But for example, they have got, apart from a commissural MR, if there is a anterior mitral leaflet tear or a posterior mitral leaflet tear, these are the patients who are going to perform worse. Next please. So you need to, this is a very interesting, very beautiful 3D echo images. So as you keep doing 3D echo, you will be able to see these things. Next please. So if you go to the previous slide, can you go to the previous slide? Previous one, yeah. You can see that these commissures are free. Here you have got the anterolateral commissure is much thick compared to the posteromedial commissure. So this is a very important point. So you need to estimate the commissural morphology if you got 3D echo by 3D echo. Next please. Now if there is a central MR like this, usually they do well. You can see the commissures are split on both the sides and you have got a central MR. This is a good result. Next. Whereas if you have got a commissural split plus a anterior mitral leaflet tear, those are the patients who are going to do a poorer outcome. So you need to look at the mitral wall regurgitation if you develop what is the reason for the MR after that. Next please. Then assessment of the right heart, you have to look at the organic tricuspid wall disease. If the tricuspid annulus is more than 4 centimeters, these patients, despite a successful BMV, they tend to have a persistent right heart failure. So you need to be careful when you choose these patients. Next please. Then other features are aortic tricuspid wall and assessment of left ventricular function. If the left ventricular function is depressed, always consider underlying coronary artery disease, underlying myocarditis. So if there is a LV dysfunction in a patient with mitral stenosis, please consider what is the reason for the ventricular dysfunction before you proceed. Next please. Absolute contraindication, our colleague has already covered that in the previous talk. Next please. And this is the summary. So I would conclude, I took a little longer time, but I thought that this is an important topic for us to estimate the assess the mitral wall apparatus by echocardiography. You have to assess the mitral wall morphology, mitral wall severity, what are the favorable features, what is the post-procedure mitral regurgitation, and what are the contraindication. All these parameters have to be encompassed in the echocardiographic report. Our echocardiographic report is a reflection of ourselves. So our report should reflect our abilities, and that is the best tool what you can, how you can market yourself. I think. Thank you very much.
Any questions you can feel free to ask Dr. Raghu. As Dr. Raghu said, estimation of post-procedure mitral regurgitation is very, very important. One have to be very keen in assessing the mitral regurgitation post-procedure because even if it's a moderate MR commissions, through the commissions, patients do tolerate very well and it will come down. But if there is any chance if you are missing AML tear or PML tear while doing echocardiogram, that's very, very important because majority of times our technicians will be doing, they will be reporting as a mitral regurgitation. If you don't look personally, if you miss a tear, an AML or PML and some simply discharge the patient taking it as a moderate or MR. And we have seen a lot of patients coming with a refractory right heart failure which are in an inoperable state. If you do surgery after 2 or 3 weeks, if the patient doesn't really follow up. And that's very, very important. We should check personally for mitral regurgitation. We should never miss a valvular tear post-procedure. That will have a catastrophic outcome in the follow-up. Thank you. And I invite Dr. R.K. Jain. Sir, please come and honor Dr. Raghu with a moment. Very well. Meanwhile, we are getting ready for live case. Professor Dash.
Yeah. Good evening.
Professor Dash.
Yes, sir.
Sir.
Any speaker there to go connect or transfer? Oh, here. Okay.
Are you able to hear us, sir?
Yeah, I'm hearing.
Yeah, sir.
Just to
Thank
present what the case. Present what the case.
Lakshmi Tarasana sir, patient.
Yeah, take present. Present. It's 26 or lady something. What is the what age with the patient? Age of functional class, tell me.
33 years sir.
So this is a 33-year lady and a functional class 2.
Dr. R.K. Jain sir.
You're not able to hear me? Are you able to hear? Are you able to hear? Are you able to hear? Are you able to hear?
Yes sir, we are able to hear you sir.
This is a 26-year lady, functional class 2, shortness of breath and in sinus rhythm. And is echo, what do you score? Tell me, doctor, what do you score?
Can you show the slides of the case? Lakshman?
No.
Case slides tonight. History slides are there. Can you show them?
They will show the slides, sir.
Yeah.
They have slides.
Dr. Dash, Dr. Jain and Dr. Raghu are here. So, so probably this, somebody is presenting the clinical history. So once it's done, who is presenting clinical history, Lakshman? Dr. Dash, are you able to hear us?
Yeah, I'm able to hear you.
Okay. So I think somebody coordinate to put a collar mic for Dr. Dash. Okay. Yeah, please put.
Rest table, guys.
But we're not able to see.
Rest table, somebody there, take rest table.
Okay, we can hear you.
So, what is the history?
Lakshman, history. Yeah.
What is the history?
Dr. Lakshman will be presenting the history.
Good morning sir. Our first live case is a 34 years female, post CMB status in the year 2001 and post balloon mitral valvuloplasty in the year 2016. Again now she presented with restenosis, severe mitral restenosis with mild mitral regurgitation, 1+ MR with severe pulmonary artery hypertension, sinus rhythm sir, and she is clinically stable with NVHA class 2 sir, clinical. Now we will show you the echo picture sir.
Dr. Dash. Dr. Dash, I think I would, you can keep working and then they will present us the echocardiography and the clinical picture already Dr. Lakshman has presented. I think as per the data, she has a closed mitral valvulotomy. That's what?
Yes, sir.
2001.
2001, sir.
And 2016 she had a balloon valvulotomy. And 7 years later now she has a restenosis. So it's a restenosis patient. Very interesting natural history of the mitral stenosis. So from you, based upon your long experience, how do you deal with these patients who underwent who have a restenosis following a closed mitral valvulotomy?
Same as
What are your outcomes like? They have a repeat restenosis, or what is the
repeat resistance is little more.
little more?
Yeah.
Okay.
And also you won't get excellent result because you undergone twice intervention.
But
One surgery, one mitral balloon, so you won't get excellent outcome. You won't
Okay.
get excellent outcome. So, can you lift?
Yeah.
Table lift, please. So I have taken two lines now, the artery and vein from right groin. So what my practice is that I keep the wire like this, venous wire, and I don't want to keep the pictal catheter long in the outer root. So I take the Mullin sheath now, taking over the 035 wire. Give that a bowl with the water, please.
Dr. Dash, just we'll switch on to the echo pictures. Can you show the echo pictures? Lakshman, it's very interesting to show the echo pictures. Can you play the video if it's possible? You can't play the video?
Yes, sir. No, sir. We have
Please play the video of the video. I think you are all still in video.
Yes, sir. No, so we have the videos
See,
also, sir.
Yeah, please play the video. It's very interesting to see the echo
The
because
valve
you can see the grossly dilated RARV.
Yes, sir.
not only that, the valve is not good. Valve is actually, I saw, you can did my echo myself.
AML thicken and
Not
doming
very
AML, sir.
favorable morphology to get an excellent result.
Somebody has to work on the audio quality from the lab to here.
So now so for beginners, I want to keep pictal out. Give pictal catheter. Take it out. Take it
Sir,
out.
I think your audio it's good, but it's not clear to the audience here. Somebody work on that. Technician, please.
Yeah. So
Yeah, now it's clear.
for beginners, I always keep the pictal catheter in the aorta. Otherwise, I don't keep the catheter. I don't puncture also the artery.
Okay.
Okay. Go inside. Please go inside. Please push. Yeah. So now my Mullin in the
Okay.
innominated vein.
You are already going to the liquor. Can you go to lab now? Can you go to lab?
Yeah, my Mullin is not innominated vein, and I am inserting the pictal catheter. Push there. Yeah. Going easy. Yeah. So we have to reduce the fluoro as much as possible. My catheter in the pictal catheter in the aorta for the landmark.
Can you show the screen, fluoro screen, please? Somebody? Fluoro, please.
This fluoro.
Fluoro from the cath lab.
So get water,
Yeah.
water bowl. No.
Okay, good.
Plus.
Your hand, please. Green shirt. Remove your hand, please. Green shirt. Yeah.
Okay, now this is the outing pressure, and outing pressure is how much it is. Narrow pulse pressure supposed to be not very good. Output is not optimal, maybe suboptimal because of a strict tight metastasis. Narrow outing pressure and tachycardic also 104 heart rate.
So, Dr. Dash, can you just tell a lot of beginners are there, how you put the Mullin sheath, what precautions you take, and how do you aspirate Mullin sheath? That's a very important step.
Pardon?
Because how do you aspirate and prepare the Mullin sheath before you puncture? Can you just demonstrate some steps for the juniors?
No, nothing. Mullin sheath just flush it. Mullin sheath flush it, both dilator and sheath flush, and insert the dilator in the sheath, and take a wire to the innominated vein, 035 wire. So I over the wire insert the Mullin sheath. I don't take any extra catheter. People take some multipurpose catheter, put innominate, remove the wire, and put the wire, remove the that multipurpose. Then they insert the Mullin sheath. But I take directly Mullin sheath over the wire
Yeah.
to reduce the fluoro time and time for the intervention. So now my Mullin sheath in the innominated vein and pictal catheter in aorta. And give me the flush, I have to aspirate, otherwise the pigtail will be clot there. We had a case, I have...
Dash, I think what our classical teaching was, what we do is until we are ready with the whole Mullin sheath, we don't take pigtail above diaphragm. Because that 1 minute of time in above diaphragm, whatever small thrombus will form will go into the below, in the abdominal, it not go to the brain.
Yeah, that may happen. Give me the...
So what our classical teaching was always, you prepare the Mullin sheath fully.
Mullin sheath already prepared.
And then you put a broken barrow needle, prepare the broken barrow needle, and then we take the pigtail. Because that 5 minutes of time, we keep flushing the pigtail in below the
we are flushing the pigtail catheter very frequently. Now, I have inserted the broken barrow into the Mullin sheath, and I should see that it should not come out of the tip of the Mullin dilator. Okay, so I'm keeping on. Can you focus here? Somebody focus here.
Yeah, can you show doctors
focus here my hands?
And it's very important how to prepare the Mullin sheath. It's very important that how to de-air the system. Yeah. Yes, sir. Now we are able to see you.
Focus on hands.
Focus hands. Keep flushing the pictal catheter.
Angle can be better. Hands.
Pictal catheter.
Hands efficient.
Pictal catheter, flush it. Flush means you have to remove the small sheath here, small, then discard it, then flush it. Okay. Now my finger is there. There should be a gap between the. This is the pointer of Mullin sheath and the hub of the Mullin dilator. Otherwise, the broken barrow will come out of the Mullin sheath. So now keeping 3 o'clock position. 3 o'clock position. I'm keeping 3 o'clock position. I'm gradually pulling down. This is my procedures, and pull down this. Push table, please. Push table, please. Push table. Push table. So I keep here just above the in SBCRA junction and above the pictal catheter. Then go to left lateral view. Left lateral 90 degree.
Can somebody show Dr. Dash hands
left
and
lateral.
fluoroscopy picture in picture here? Both picture in picture.
Go left
Do
lateral.
that. From the cath lab, show both Dr. Dash hands manipulation and fluoro images.
Left lateral fully left lateral. So I go to left lateral and showing the 3 things: on sternum, spine, and diaphragm. Inject now. Give
No.
Somebody know that you do that. Somebody know. No contest. That's contest. Whoever know, you know how to repeat himself. Just do. You are taking some.
Yes.
You are.
He is training and injecting.
Okay. Inject now. Inject. Slowly.
Can you show the fluoro now?
Inject. So now.
Fluoro, please. Yeah.
Now my catheter almost between the spine and the pigtail and below the level of pigtail.
Yeah.
And then I see in the frontal view again. Come back, frontal view. Frontal view. Frontal.
No, this is a lateral view, you said. This is a lateral view.
Lateral.
So this is a lateral view.
Come to
And
frontal.
this is the lateral view. These you can see the spine and
Come to
sternum.
frontal view.
And you can see the pigtail. And
So
he's
now-
now is a coming.
Now it is frontal view.
Yeah.
So what to do? I just little counterclockwise the needle and pull down. I only try to puncture the septum just right bottom of the spine. Now go to lateral view again. Go lateral view. Now I'm fine. Come to frontal now. Frontal.
AP.
Maybe. Now I already punctured. Inject.
Yeah.
Inject.
Yeah.
Inject. Forcefully inject, yeah.
Contrast.
Okay, now I am in LA now. So now pull it out, flush it. Take pressure, give pressure.
I think it's very important step for the beginners here. When you
Plus,
go with the needle, somehow that contrast was not visible here. is already with a dilator there, and now the next step of sheathing
So,
into the LA and removing the dilator is very
now
important.
in LA now, the LA
Yes, sir.
pressure is how much LA pressure? And I'm flushing the pictal catheter. If I are going to methodically, then I enter into the left ventricle, take the diet, and simultaneously take LA and LV pressure. But I'm not doing that because I've got information from
Paniteja,
echo.
can you tell the cameraman to show both Dr. Dash and
So
the fluoro
focus light,
images?
focus there. Dear, focus there. Focus there. So LA is quite high. LA, how much LA mean? LA mean किधर लिखा है? LA mean, please. LA mean, just read it up. No, how much it? LA mean 38.
38, yeah.
So LA mean 38. Okay, so it's quite high. The upper limit of its normal LA is 15 or 12, 15. So LA is 38. PVH is severe PVH.
Yeah.
So obviously you have patient got severe PH. You know that transpulmonary gradient, you know that. So PVH is severe, 31, 38, almost 40, close to 40. So patient has got severe PVH because he has long-standing mitral disease and undergone 2 procedures long back. So now what we'll do, I pull down pictal down a little bit, not to keep there anymore in the aorta. Let's take the LVR now. Yeah. So now aortic pressure is normal. LVR. Come close to me. Push. Left hand go and push. You're done before? Push. No, छोड़ो, leave it. Should leave to me. Fluoro.
Can you show the fluoro now?
Fluoro देखा यार.
Fluoro, please.
Somebody should fluoro.
Yeah.
You're showing fluoro. Can you get the camera close to keep the monitor close to me, Manisha? So LVR in the left atrium. So I'm pulling out the Mullin sheath and dilator, keeping the LVR there, and I'll take the septal dilator. Hold please, hold. Please heparin.
Now you give
100 units per kg, please. I'm sorry it is a bit late. 100 units per kg. What is the weight?
4,000.
49. 5,000. Give 5,000 heparin, please. 5,000 heparin. 5,000.
So
They are giving, sir.
Yeah.
So 100 units per kg.
Rajendra, when you puncture the septum,
Immediately I have give heparin.
yeah, okay.
You should have reminded this, here the work of the taking son and nurses to remind us to give heparin.
Yeah. So heparin of 100 units per kilogram has been administered.
So when you are
And-
doing left heart study, always take 100 units per left hand, 100 units per kg. So her weight is almost 50 kilo. So we are taking the 5,000 heparin given intravenously. Of course, you have given IV antibody given before.
Yeah.
Okay, fine. So now show here how we are dilating the groin.
Yeah.
Groin. Groin. So instead of pushing like this, you should do like this. So it will go easily.
Hello.
Are you able to see now? You go like this, it will go easily. Now under fluoro, going to dial the septum. Leave. So it is going easily.
Yeah.
There no resistance. So done. Maybe you are doing twice or thrice. Okay, fine. Hold here again.
There is no groin fibrosis from the previous procedure.
Yes. Holding there. It should not come out. Okay. Holding it down.
Actually, the practice patterns grossly vary.
So
Once
the
the
groin
septum is
dilated and
punctured,
septum dilated, taking a balloon now.
we have been trained
Our
on
weight is almost 160.
For example, rest of the procedures, when
So
they put the
159
wire,
or some 150
here we are
centimeter her
advancing
weight.
the
So we have
middle.
taken,
Yeah, Dr. Dash, we are with you.
her weight was 159 centimeter. So we have taken 1 centimeter less because
Yeah.
as previous intervention taken 1 centimeter less, and valve is not morphology is not very optimum to get an excellent result. So we are taking 1 less. So how much taken? 25. Hold properly, please.
I think in this patient, once again, because
Sure,
we had
sure.
previous interventions and all,
Is it-
one needs to be very careful
Hold.
assessing the
Hold.
valve
Chodo.
and also the commissure. That's why he is taking -1. because of multiple previous interventions.
What are your recommendations, Dr. Dash, whenever there is a case like this with dense subvalve fusion, whether you choose a low profile balloon or you take the balloon according to the size of the height of the patient?
Low profile balloon means?
I mean, suppose lesser size, you go to higher pressures or you go with a regular size with go to 100% inflation. Suppose especially in a subvalve or with a dense subvalve.
Correct. Subvalve means you get less, no, naturally you go to less volume uptake. Less volume. Holding. So similarly you do like this, focus here. Focusing.
Can you push
focusing here?
Yeah.
So like this, so it will go easily without any problem. So fluoro thing now. Focus fluoro. So now this is a limiting step.
Yeah.
So when you push the balloon, if you puncture tangentially, so balloon entry into LA is difficult. So now almost tangentially I punctured, but still so leave it. So I have to screw. I have to do counterclockwise, clockwise to the balloon, holding the wire here. So I'm not able to go. Now difficulty because of the thick septum. So now I've gone whole of the septum across. I am totally LA.
Yeah.
Otherwise you cannot remove the stretching tube. Now I am removing the stretching tube.
Can you show the hands please again? Dr. Dash, can you teach the young people how to disengage the metal stretching rod and the balloon? Yeah.
How to remove on? Yes. So now I have to remove first the golden things. This one.
Yeah.
Golden.
First attack.
That is a part of the balloon. Now I'm unscrewing the stretching tube and pushing this over the wire and pulling out whole of the system. Come to RO. RO. Yes, RO. Now only the balloon in the left atrium. Now I'm cleaning and aspirating it. Aspirating. You should have free blood should come out. Now I'm taking the stylet. Give me stylet, please. Stylet. Take the stylet. Leave it.
Do you shape the stylet, Dr. Dash?
No. It is a new one.
It's a
not
new
old one. It is a new one. So let's see if it goes well. Okay. Otherwise,
Ramaraju should have given the old one because you're experienced operator.
see now. Don't you know that? So now I'm doing some here. My hand counterclockwise rotation of the stylet. So it is bob there. Then I push it because no. I will tell you. It should be free. Otherwise, you will get severe MR. He has got severe subvalvular disease. Okay, now it apex. Go. Little slow. Little give. Kodiga. Give little more. Bas. Don't do anything. Dilate fully dilate. Okay, deflate. Yes. Now I am watching the FA pressure.
Can you show pressures please.
Pressure dekha? See, listen. Pressure has come down. So two things. Either the patient has got transient ventricular dysfunction or patient has got significant MR. Two things.
There's no tachycardia. I think there's not much of MR.
There is no tachycardia. So probably because of severe PH, now the obstructed the valve for a long time, and again there is a transient right ventricular dysfunction. So RV output is less, so the FA pressure is less. Probably. Otherwise, I would think patient develops severe MR. Obviously, the valve is not good. We may expect also MR also. But here, the pressure has come back to normal. And let's see the LA pressure now.
Dr. Dash, how will a young operator differentiate whether the balloon is in the subvalvular apparatus or not in the subvalvular apparatus?
It won't open here. The distal one won't open. If it's subvalvular apparatus, distal balloon won't open.
Distal balloon won't open. Means won't open fully or Even
You won't,
partially
you won't
also it will
open,
not
your proximal will open.
Pardon, sorry?
The distal pad won't open, proximal will open. If it is fully subval, very and too much disease and valve is subval. So now LA has come down to 42, 23. No, 23, no?
Yes, sir.
29. So probably we may not expect to come down further because what? Because you see echo. Let us see.
Dr. Dash,
Yeah,
can you just put the pigtail in LV and check the gradient?
I am taking now.
Yeah.
So give wire to pictal give. Sorry, the wire give. So before that, please flush the pictal. Okay, don't put the wire immediately. Throw this. Check for MR. Check for MR. Just check.
Color.
Echo, can we have a look at the echo if it is possible?
No MR. There is no MR, but there is some substantial gradient across metal valve because valve is not good. So we come to okay, fine.
Yeah, that's too much of because yeah, but acute MRs usually we miss by auscultation. That times, yeah, it's not that. Yeah, it is those. Yes, it's those.
I think still the mean gradient is.
We use it's a most reliable thing is taking a LA pressure tracing. If the V wave is prominent, it itself indicates that there is a severe MR.
Mean of 9, sir.
Oh, okay, fine. That's okay. 3 times intervention, so we'll accept it maybe.
Mean grade 39.
Now,
that is
now LB and LA take simultaneously.
mean
There is some
echo
gradient there. Make it speed, make 50 speed.
It's almost anything 50 more than 50% reduction in the mean gradient is considered as a successful PBMV.
Slow change.
Dr. Dash,
Yeah.
see as a safety, usually what we do is after entering LV, we try to check the mobility of the balloon from the apex to the mitral valve.
Yeah,
If it
that
is
is
only
then
freely mobile, we will inflate.
Still some gradient is there.
I think
But
next
you can't
workshop
expect
for you
here.
will be 100 cases of MVR. We, Dr. Satish, all these reasons is MVR Satish will do.
Now 25,
So plan for
26.
MVR, 100 MVR. So how to do MVRs?
How much coming here?
I think you should keep a good database of all these people and all 100 MVRs you can do here.
Now your EDP.
Yeah,
how-
very
how
much crossover.
How much EDP is coming? EDP? Can
Can you show hemodynamics pressures, please?
Yeah, when you show how much EDP?
Pressure. Can you show the pressure
How come
tracing?
6? How much? Make
Monitor.
it, scale, increase the scale.
Monitor. Not
Monitor
this
scale.
one, the pressure one.
Pressure monitor.
More than that.
And increase the speed, I think. Somebody, cath lab technician, increase the speed of the tracing.
What about echo?
Echo, no, mean gradient 9.
Yeah, what about commissional?
Commissure split, both commissure split.
Very good. Gradient has significantly come down.
Both commissure split.
Yeah, cath lab technician increase the scale,
And there
decrease
is
to 40.
There is mitral annual calcium there. And both commissures are split. Mitral annual calcium there. See gradient right now, it heart rate's come down. See gradient how much? Now LA pressure is 25 now, 23, 22 LA. And LA, the LV EDP is coming around 10, 12, 15 also.
తీసుకున్నా ఫస్ట్ తీసుకున్నా
Mean is 8.
Mean is 8. So this is your now pressure tracing.
Dr. Dash, you want to further dilate because you did -1. You want to go ahead with the full dilation?
No, I don't want to go because I always prefer suboptimal result than MR.
Yeah.
because she has got already some trace MR, the mild MR there.
Okay.
The valve not that good. Valve
Yeah,
very
valve
bad
is not good. I will also
Very,
not
very
suggest to
bad
go
valve.
for full dilatation. Yeah. I accept your.
only thing that we can go to same volume, can dilate. Same volume I can dilate. Give him the.
We have a lot of patients, even with suboptimal dilatation and average result, they do very well. For many years, they will be asymptomatic. Yeah, sure. Okay. Yeah, that's true. That's true.
No, that is because of placebo effect here.
I think the definitions of success of
No,
the
don't
balloon
worry.
valvotomy
Nothing happened.
needs a redefinition because if you look at it, both the commissures are split here. So once the commissures are split by doing one more balloon, what else we additional will gain?
That's
So whatever is the additional gradient is in the subvalvular region must be there. That 8 or 6, whatever is pending.
Dr. Dash, you change your mind if you're going for another 1 plus?
No, another balloon the same volume.
No, but you increase your.
Increase? I'm going one more time to same volume, same volume. Okay, it's very much free. Okay, give inflate. A little further inflate. Blast. Okay, now open well.
Audio. We are not able to hear you, sir, from the from the main lab.
Now there no gradient. There almost no zero gradient. Zero grad. So the back to the. Are you able to see the tracing? Are you able to see the tracing? I'm not able to hear you. I'm not able to hear you. No gradient.
Sir, actually we are not able to hear you from the
Now
main
can you listen to us?
Yes, now.
Yes, sir.
Okay.
So now
Can you
there
show
is-
somebody show the monitor, please?
Monitor dekhav.
You show that. అది వెళ్ళట్లేదు రావు ఒకటే
Monitor. No, not this monitor. Pressure monitor.
Yeah. So there is no gradient.
Oh God, it is super now.
Yeah.
Oh, wonderful.
Yeah, there is no gradient. This is super.
విల్ షో ఎకో ఓకే
Yeah, it's good.
Echo dekha.
ఎకో గ్రేడియంట్
Yeah, I think cath lab technician ఎవరున్నారు? Cath lab
Oh, oil open. Valve is oil open.
Cath lab 2, sir.
cath lab technician showing on 40 scales.
Now so the echo.
The pressure
to
showing 40 scale.
my
It's in 100 scale. So
sister. Very good. So that
this is good.
very good.
Echo trace, yeah.
No gradient.
This is good. No gradient. Yeah, this is fantastic. So everybody's audience asking what's the rationale of dilating with the same volume balloon second time?
No, only thing very careful. Should not rupture cardi first of all. You
No,
should
no.
be
No. What is the rationale of dilating the mitral wall with the same volume balloon?
for the risk.
Not the risk, but how did you achieve a better result?
No,
with
actually,
this?
what happened? Actually, it was hold in the proper place. So first time it was little below the valve actually. So the commission not oil split. Now commission split oil.
Okay.
So see, these are things that
I think the person who inflated the balloon
Yes.
did it well second time than the first time.
yes. See, it is done better than
Dr.
first time.
Jaishankar used to tell us how to inflate the balloon. He said that you should do with a oh. If you don't get that sound, he used to upset us.
Okay, fine. So
You
give us
should-
the
you should tell-
tube and pulling out.
That who will automatically come if there is a dense subvalve.
Pull inside. So now I am pulling out the balloon from the left atrium. So this is the
Yeah.
stretching tube with the wire inside, LA wire inside. Don't advance. Don't advance. I will let you know. Come to frontal.
Yeah, can you show the fluoro also now both how the LA wire goes and how the remote? That's a very important step.
Yeah.
Otherwise they'll damage the balloon and
Otherwise we damage the balloon.
who's our cath lab owner is there, they'll make a lot of
People, they have
losses.
damaged the balloon
If
before.
one
like
balloon
this.
is gone.
So now keeping in LA and putting the wire first. So wire full that the coil parts will go out of the. Then You slowly
Yes, now we are
advance it
Very-
and
70?
70, latest 70,000.
Ramaraj,
It's
that's
more.
why you're doing workshop. No, no, now we know why Ramaraju has accumulated the cases. Dr. Dash,
sir,
you know why Ramaraju is doing this workshop?
tell me.
The PBMV reimbursement is
That's
getting
true.
is 70,000
Yeah,
now.
that's one of the reason. See, we cannot conduct a workshop with the PBM for 24,000, which we are used to do. 26.
From Hyderabad, we'll shift all the cases here now.
Ah, sure, sure.
What to do is you
We'll give you a good referral amount also.
press or give stitch.
No, sir, they will press.
It's very good.
Give a stitch this one because it
No, no,
takes a
very
long time to
good.
close.
70,000 is
Press
very
stitch
good,
and
very
you
good,
press it,
excellent.
press
It
both.
needs.
Get the value.
Just because the rates are less, they don't want to take the risk.
We represented to the authorities that you should at least give 60. But somebody was there in the committee who was sensible enough. They made
No,
it
not
70. Otherwise, we had to use the
No,
charge
yeah, nice.
it how to headache.
మా అయిపోయింది మార్చేస్తాం వాటిని
I think this reimbursement level is a reasonable number.
Yeah.
It's a reasonable number. I don't say you should charge at least 100,000 rupees for a balloon. Otherwise, it doesn't become viable with
You
a
know how to
good
remove?
quality of material.
You do without gloves. Oh, sorry, gloves.
No, the Ture balloon
Thank you
itself is
very much.
86,000
Thank you.
or something.
థ్యాంక్ యూ
I think
Ambura is also around 39,000.
Dr. Dash, excellent case and demonstration. Thank you.
No, excellent
Thank you,
result.
Thank you. Thank you. Excellent result.
For a re-stenosis.
CMV, PBMV, PBMV, and third PBMV, no? It is a second PBMV, and with the mitral and one third intervention. It's very good.
Stop.
Huh? I request Kumar sir to give the bouquet to Raghu sir.
గురువును మించిన శిష్యుడా గురువును మించిన శిష్యుడు అనే సినిమా ఉంది ఈ గురువుని ఎప్పుడు మించలేదు
I request Dr. PBNM Kumar sir to. I request now Dr. PVNM Kumar sir, Senior Consultant Cardiologist, Care Hospital, Vizag, to deliver his talk on 3D echocardiography in assistant in role of PBM. Thank you, sir.
Is there any tea break or shall we go ahead? Ramaraju? Dr. Ramaraju, is there any tea break or we are going ahead? నేను టీ తాగానే చెప్తాను నాకేం లేదు అదర్వైజ్ ఎవ్రీబడి కెన్ హ్యావ్ ఎ కప్ ఆఫ్ టీ అండ్ సిట్ అండ్ లిజన్ షల్ ఐ స్టార్ట్ స్లైడ్ ప్లీజ్ గుడ్ ఆఫ్టర్నూన్ ఎవ్రీబడి క్యాన్ యూ స్విచ్ ఆఫ్ దిస్ లైట్ దిస్ లైట్ ఏమైంది So good afternoon everybody. This is a very peculiar situation and a talk which was given by Ramaraju to me. When there is PBMVs, plenty of cases, I don't have 3D echo with me. When I have 3D echo with me, I don't have PBMV cases with me. So this is a very peculiar situation, and to be frank with you, I never did a single PBMV with 3D echo. I am also learning with you. So let us go ahead and see what we can do in future. Can you have the slides? So with this background, with my learning things, I will try to make it more understandable to you people also, what I understood all these days, and we'll see what will happen and how I am going to complement the talk given by Dr. Raghu. So when you have a 2D echo which has given the whole thing what you require for a PBMV, how this 3D echo is going to help? That is the main thing what we are going to talk today. Is it okay? నా కనెక్టింగ్ ఏం ప్రాబ్లం కాదు కదా. So, as you all know, the rheumatic heart disease, it is still endemic in India, particularly in Rajahmundry, that has proven by our Ramaraju, keeping so many cases. That's why we came here to learn about PBMVs. Echocardiography, the uses of it already spoken by Dr. Raghu. I thought if Raghu misses this particular workshop, I can do some of this job. And finally, why we need a 3D echo when 2D echo does most of the job. So there are some limitations with 2D echo, and somebody who is not having a 3D echo at all at their institution. Can I have the raise of their hands? Anybody having 3D echo in their institutes? Only bada people is lifting hand. It's very difficult to understand other people also. Just I will try to do my best. So you have to know the limitations. I will go across of the 3D echo. Why you need a 2D echo? Why you need a 3D echo? And how is 3D echo is different from 2D echo, and what are the 3D, how the 3D complements the 2D echo, and does 3D echo has any incremental value over the 2D echo, and then is performing and getting the 3D echo images is very complex or it is simple, and what is the role of 3D echo while doing a PBMVs, and can 3D echo predict immediate outcome after PBMV. This is the main thing what I wanted to cover in this particular topic. So as you know, the 2D echo does not have unless you have a good acoustic window, getting a good 2D images may be very difficult, and resolution compared with 3D echo, 2D echo images will be poorer, and there is lot of inter-observer and intra-observer variations. One time if you see for same patient, the mitral area will be different when you reassess the same patient or the second person assesses it. So the sort of problems you will have with 2D echoes. And the 2D echo Doppler studies are also influenced by hemodynamic status of the patient, like heart rate, rhythm, and the compliance of the left ventricle, like old age people, and the associated valvular lesions. So with this background, we have to know what is 3D echo. This 3D echo came into emergence into the practice when you developed a phased matrix array transducer probe, so that you can cut the mitral wall in different angles. That I will show you. So initial application of 3D echo was regarding to the LV/RV volumes, mitral anatomy, the stenosis that we are doing, and there are investigational things also going on the 3D echo. And this is what happens in the 2D echo. You can see that there is only one plane through which it is going. So it is going only one plane. One second, I want to show the pen. Are you able to see it? No. It's not visible. Fine. So you are able to cut it only in one plane. That is called as B mode. Whereas in the 3D echo, you can see it in 3-dimensional. What are all the dimensions? We'll see. So this is the probe what is used to acquire the images and all. And this is the way how the crystals will throw the ultrasound beams into the heart. When we see a regular mitral wall in 2D echo, you think it is a flat structure and it will have commissures and it is attached to the annulus. That is what we thought when we are all studying in our study period, that mitral wall is a flat structure and a oval structure. Apart from that, we don't have much of a knowledge about the mitral wall. But once with the invent of this 3D echo and its examination assessment of the mitral wall, it was shown that mitral wall is a saddle shape, non-planar mitral annulus. That means it doesn't have a same plane. So there is this particular 3D echo will help us to assess the relationship of the papillary muscles with the mitral wall, and also this is the first time where people able to measure the mitral leaflet size in a beating heart. The measurement of these things are all important when you are doing a procedures like mitral clips and percutaneous mitral replacement, but not in the situation of PBMVs. So this led us to develop a non-planar mitral annular rings, and they could able to understand the mechanism between ischemic and functional MR, and also the mitral wall prolapse criteria has also changed. So this is a mitral wall what you see regularly in 3D echo, but you can compare this with a potato chip, where you can see the anterior posterior thing will be at a higher level and the commissural level will be at a lower level, right? So this is actually the shape of the mitral wall. So if you superimpose like this, and you can reconstruct the mitral wall, that we'll try to show in some of the real time cases. So you can see the mitral wall, how it is moving, like how is the mitral wall movement, and how it is going up and down, how it circumferentially it is moving, and how it is counterclockwise rotating. These are all the things what you can make with 3D echoes. So before understanding the 3D echo, you should able to know what are the various angles of 2D echo what you already know, that will be helped to identify the mitral wall properly. For example, if you take this parasternal long axis, that cut which you are seeing in the extreme upper one, you can cut the mitral wall across the A2 and P2 scallops. You all know how the mitral annulus is divided as anterior leaflets and posterior leaflets, and the anterior one will have A1, A2, A3 and posterior P1, P2, P3. These things you all aware of. So how the parasternal long axis cuts across, how the 4-chamber cuts across, what are the leaflets, these scallops you can see, and then you can, the 2D echo, the problem with the 2D echo is, if you do some angulation of the probe, and if you are not able to properly visualize the wall, you can overestimate the mitral wall area also. This cannot happen with a 3D echo because of the various reasons what I am going to tell you. So 3D echo will not affect the thing. So for every case, these are the mainly for the patients of going for the mitral clip and rest of the mitral procedures. You should give a surgeon's view how the mitral wall is going to appear by taking the various images. So the main advantage of 3D echo is that it does not take into consideration of any geometric assumptions or the plane position of the thing. So to understand it, I make the talk very simple. 3D echo modalities will be two types. One is acquisition modalities and second one is the cropping modalities. So in acquisition modalities, the first one is biplane imaging or X-plane. That I will explain you. The second one is real-time 3D imaging. You just remember these pictures so that you can understand what I am going to talk. Third one is 3D pyramidal or full volume imaging. And fourth one is a 3D zoom imaging. This is the four types of thing where you can assess the whole mitral wall in various angles and with TE also, so that you can get the maximum information regarding the mitral wall. So first coming to the biplane imaging is nothing but at the same time you can get two orthogonal planes of the 2D echo along with the color. Here you can see, for example, you can get a parasternal long axis and short axis view, and simultaneously you see how the cardiac structures are visualized. This is particularly important in case of the PBMV, because if you can see there in that particular image, you can see the parasternal long axis and the mitral valve movement. And once you cut across this leaflet, you can see exactly how the mitral valve is positioned, and you can get the exact location of the mitral valve area. And you can also assess the various segments of the mitral scallops. This is called as simultaneous biplane imaging or X-plane imaging. So this is also useful for septal puncture. Septal puncture, what you have to know, where you have to puncture the septum. So usually you have to locate the fossa ovalis. By fluoro, it is the most blunted procedure, unlike coronary, where you don't have a 3-plane view of the image. You can only have a 2-plane with a fluoroscopy. So to give the to get a 3-plane of the intraatrial septum, what you can do is this, as you know, the aorta, this anterior structure, and anterior inferior one is the anterior posterior. Second one, this is SVC, and this is IVC. So superior inferior. So you get anterior posterior view of the septum as well as the superior inferior view of the septum, so that exactly where you can puncture, this biplane image can help you to position exactly the broken barrow needle. And most of the times, because of the altered morphology, where Dr. Ramaraju does in so many cases with scoliosis or large atrium or sometimes IAS aneurysm, where you may not be able to clearly assess the location of the intraatrial septum by fluoroscopy. In these locations, in these situations, probably this biplane view will be useful. And here you can even have how much distance you have punctured the septum from the mitral valve. This distance also you can see by forming a denting with the broken barrow needle. So that is how it will be useful. Sometimes if two orthogonal planes shows that the left atrial appendage is having clot, that is a definitive indication for postponing the case for PBMV, giving some anticoagulant reassess. So that is about the biplane or X-plane imaging. So 3D imaging, to understand real-time 3D imaging, I project 2 slides. Just concentrate and then you understand about the 3D imaging. So actually what is 3D imaging means, whatever the beam that goes, it will create a pyramid-like structure. And this pyramid have 2 things. One is the beam mode and second one is depth. That is called as C-section. Okay? This is a wedge sort of 3D image. So if you can see there, this one is a beam mode and this is the cross section. That is C-plane. So there is 2 planes which creates a 3D image. So this C mode is the one which you can place near the mitral valve like this. And this particular 3 mode, this C plane can be rotated some 3 degrees to 6 degrees, and you can cut at the various levels close to the mitral valve, and you can get the exact picture of the location of the mitral valve area. Okay? You can get almost all up to the image of 24 image planes by having these particular cuts. So this is what I said. In this particular pyramid, there is 2 things called is, one is lateral, this one, and one is elevation, this one. So accordingly you can adjust the width or the depth of the lateral as well as the side angle of this pyramid. So now with doing all those things, you will get a exact mitral valve areas in a 3D echo. Compared to the 2D echo, this real-time 3D imaging, because of this multiple cuts and making an exact measurement, you can get a very high spatial and temporal resolution of a mitral valve that will be useful for initial evaluation of the mitral valve. There are studies which compare these 3D images with routine mitral valve images, where you can see this 2D planimetry assessment, and it was shown that it is highly reproducible with the 3D planimetry. And even transesophageal echo doing real time also showed the same thing, that the assessment of commissural fusion is better with this 3D real view. So next, coming to the full volume view. In this, what happens, instead of a narrow pyramid like structure, you can get a whole volume of the cut what you are taking into image, and that thing you can crop, cut, do several things and get the exact area which one you want to assess. So in this one what they do is they cannot get the whole volume, full volume in a single frame. So they will try to make a different cuts of the image at each beat of the heart, and they try to stitch those images. That's why you will get a thing called a stitch artifact that I will show you. So this one, because of the huge image, the spatial resolution, is clarity of the image will not be so good. Once you do with an ECG gated cuts like this, so this particular volume will be found with different ECG beats, and it will stitch all those things, and then you will get a image something like this. So if you can see this particular video, it's supposed to run. So see, it is taking different images. So four cuts it will take, and it will form one single image. That is called as full volume image. So I will play it again so that you can understand. So 1 image, 2 image, 3 image, and finally 4 image. All together it will fuse and it will form a full volume image. Sometimes if you don't properly take that cut, there will be some stitching type of images. During this procedure, one thing what you have to do is try to get that cuts into 2 bits also you can get. This is a 4-bit cut what I have shown. You can get a 2-bit images also. Patient has to be asked to hold his breath. These are the 2 things what you have to follow with a full volume imaging. So with this, you can see the entire mitral valve apparatus. Most of the times we use these full volume images in the setting of CRTDs, where we do very frequently, and we assess the left ventricular volume and how is the geometry, how is the dysynchrony. All those things will be done with full volume image, and then we can get the LV size also. I will show that also. As I said, because of poor spatial and temporal resolution, it is given as an ECG gated one. Okay. Most of the times we use this for LV assessment. You can see that the different angles like 4-chamber, 2-chamber, short axis, everything will be taken. This is called as multiplanar reconstruction. And subsequently with all those things, you can see how the LV is contracting. This we can show for the mitral valve also. So this is what the importance of doing an MPR and the full volume image and getting the various volumes of the things what we want to assess. Okay. So this is how you can get the various multiplanar reconstruction of the mitral valve, and ultimately you can get the mitral valve area like that what you are getting. That is the exact area which correlates with the Gorlin's method of estimation of the invasive thing of mitral valve. Sometimes you can that the image what I have shown before you can do even one thing called as mitral valve navigation, and you can mark the various things in the various angles, and then you can even reconstruct the mitral annulus and mitral valve like this, the lowest image. So this is the whole mitral valve with anterior leaflet, posterior leaflet, and you can get the each and every details of the mitral annulus, leaflet area, leaflet volume, leaflet length, how it is coapting. All these things you can make with this mitral valve. So this one which I have shown before, and this is the 3D imaging. This is the most common thing which is used for the AV valves as well as the intra-atrial septum. So you will get a cut, and it's a zoomed cut where you can tilt this one above and below, and you can see the left atrial side as well as the left ventricular side if you take a 4-chamber view of the cut. So I am supposed to keep an ASD image for you. So this is how the mitral valve you can assess in parasternal long axis and 4-chamber view, and you can see the various leaflets, how it is positioned, and you can get like images like this. So you can take a 4-chamber view, and you can see from above and from below, and exact location of the mitral valve area can be assessed. And you can see the commissural location, how it is placed, pre-PBMV, post-PBMV. I will tell you regarding those things. These are all the various cropping methods that by practice you will come to learn. So the different modalities of 3D what used in mitral stenosis, explain what I explained about the IAS location, how can you identify the puncture site, left atrial appendage thrombus, and mitral valve real time, how you can crop the leaflets, and how you can assess the mitral annulus, different leaflets in full volume and focus 3D for the LA and LV view of the mitral valve. So with these things, is there any difference between one modality to other modality? So they have done the studies between the 3D zoom versus full volume. But finally it has shown that it is much easier to do a 3D zoom. That is what the routine practice for all mitral wall area assessment, better than doing a quantification, which is a tough product. But the newer machine has come with single touch of button, you can quantify the mitral wall also. So the echo of this 3D, when you compare it with the 2Ds, there is less number of moderate cases, but by doing a 3D, the number of moderate mitral stenosis has been increased. So you are able to identify more severe mitral stenosis cases compared to the 2D echo with 3D echo. So this is the one study which showed that the spherical shape of the left atrium, size of the left atrium, has the more chances of having embolic events compared to the regular size of the left atrium in the mitral stenosis. So what is the role of the 3D echo assessment in feasibility of mitral wall? So as you all know, feasibility, how will you assess? There should be some ideal echocardiograph scoring system where it should be applied everywhere and it should be done easily, and there should be validity in TTE as well as in TE cases. This is what the score, what everybody uses, that is Wilson score. And there are many scores like his Nabayashi, as Dr. Raghu was telling, Nabayashi score, this many names which I didn't go through also, Nanan score. So, but the most of the time the golden standard is Wilson score. But it also has many limitations because you use 4 parameters in the Wilkins score, but only 2 is associated with the prognostication. One is subvalvular pathology and second one is leaflet calcification. Rest of the 2 doesn't have any prognostic valuation. That is one limitation of the Wilkins score. Second thing is actual commissural involvement is not assessed in the Wilkins score. That is most important because commissural involvement, commissural thickening, commissural calcification, all those things you cannot make out in the Wilkins score. The third thing is by 2D echo you cannot differentiate between nodular fibrosis and calcification. That is very difficult, and sometimes it can overestimate the mitral wall, and sometimes it ignores the distribution of pathologic abnormality and other subvalvular thing it may not be assessing. So there is a lot of, as I said before, inter and intra-observer variability with PBMV. For this sake, they have come with a new scoring system with 3D echo. So to understand this, first of all, this is called as an end-phase view of the mitral wall. This mitral wall, you will have an aorta here, and this is the anterior mitral leaflet, and this is the posterior mitral leaflet. You will have different 3 leaflets and this commissure. What they do is, they assess 2 things with this score. For this one, this anterior mitral leaflet, posterior mitral leaflet, they see the thickness, like Wilkins, the mobility, and calcification. But only one difference here is the mitral leaflets which are close to the commissure will get a more calcification score compared to the rest of the mitral leaflets. That's why you can assess the feasibility much more better. And subvalvular apparatus also you can see whether its proximal part is involved, middle part is involved, or distal part is involved, and whether it is thick or subvalvular separation is there of the chordae or not. So totally you will get scores like this of 31. If the mild MV is mitral stenosis is there, it is less than 8. If it is moderate, 8 to 13, beyond 1 is severe mitral stenosis. This is a new Anwar score called as Anwar score. This has used, and if you see this, the immediate success compared to the 2D echo, the 3D echo score showed that leaflet calcification, subvalvular thickening have significant p-value. Like that, this is 1 year success. 1 year success also, leaflet calcification, subvalvular thickening, and subvalvular splitting. These have better p-value. So in that way, 3D echo gives much better assessment of the feasibility of the mitral wall. So recurrence of symptoms, increased transmitral gradients, restenosis, severity of mitral regression, all those things will be better if the severe subvalvular effusion will be seen in the 3D echo. So like that, 3D echo prediction in immediate outcomes. So in this study, they did 3D Anwar score versus 2D Wilkins score, and they found that the 3D echo assessed Anwar score have superior prediction of suboptimal results compared with the 2D images. So calcification, one thing which has singly detected much more frequently with 3D echo compared to the 2D echo, and posterior commissural splitting has given much better prognosis. So this is how the 3D echo is useful in many cases, how to assess the mitral PBMV feasibility, and they have given something like how the mitral wall scallop tenting, prolapse of the volumes of the prolapse, coaptation heights, depending upon they could be able to make out the development of mitral regurgitation after PBMV. So finally, what is the role of 3D echo during PBMV? As I said, patient cannot lie down to do a left lateral decupitous position like a 2D echo. During the procedure, you can use a apical 3D echo alternatively, and it will actually, if you do the whole procedure by 3D echo, you can even reduce the fluoro time also. So first you can, one important thing is, it can sometimes delaying, like what we seen in the first cases, what Rajendra Jain is cautioning. So because patient having an atrial fibrillation, you postpone the anticoagulant for 3 days. So these 3 days patient may not be in any anticoagulation, and there will be chances of developing LA thrombus. So rapid development of LA thrombus, to rule out, it is better to do a TE during the procedure, which rules out the thrombus presence. And balloon sizing also you can do, because you know the commissures and you can see the lateral commissural length, and you can assess the balloon sizing instead of our routine rule of height of the patient by 10 plus 10. Okay, and as I said, you puncturing of the septum, whether it's anterior, posterior, superior, inferior, it can help, and it will be useful that one of the common complications is what? Balloon will be perforating the left atrial appendage. That particular complication can be ruled out by doing a PBMV under 3D TE guidance, where you can clearly locate where is the left atrial appendage. And it can even useful for the positioning of the mitral ionoid balloon into the across the mitral wall, and you can see whether this particular balloon is not into the caudal structures. That we will try to project sometime today in one of the cases. And this particular procedure you can do instead of the first case what we have seen. A stepwise balloon overdilatation can done with the 3D echo. So that's why 3D echo will be useful in the septal puncture, balloon guidance as well as balloon alignment. So this particular thing has shown only the Gorlins formula, and real-time 3D echo is only this thing which will be useful to assess the post PBMV, how is the proper mitral wall area. So overall 3D advantages over 2D advantage is what? It gives large surface area to evaluate. It has enhanced spatial orientation compared with the 2D echo, having a better quality of image. And you have accurate volumetric quantification, like in the case of LV volume or the size of the ASDs and all. And you can crop, cut, rotate, whatever you want to do with an image, you can do it. And you can even see the mitral wall in front of your face, like what are the images I have shown you. And the Anwar score was shown to be a better scoring system than the Wilkins score. And it also guides you in the PBMV as well as predict the events pre and post PBMV. So let us all become more perfect by doing more number of cases. Thank you.
Live case is ready. We immediately can shift to the live case.
Thank you, sir, for giving a comprehensive talk on 3D echocardiogram and enlightening us from basics to beyond. I think we'll be able to start 3D echo shortly here also. Sir, in your routine clinical practice, where do you prefer 3D echo? Where 3D makes a difference over 2D echo?
Usually for a ASD device closure, 3D echo is the best thing to see how many number of ASDs are present, what is the rim you have in the ASDs to place the ASD, whether you position the ASD properly or not. In routine ASD closures, we are using 3D echoes, transesophageal 3D echo. And most commonly what you is, apart from this, is volumetric assessment of the left ventricle whenever we are planning a CRTD devices. So it gives each and every segment of the left ventricle, how it is contracting, how it is delayed when compared to the other segments, and it can give it can even predict whether the CRTD procedure is going to be successful or not. So these are the situations where I use 3D echoes in our center, but PBMV after this.
We'll shift to
particular
live
thing, we
case.
have to-
Live case already is ready.
Thank you.
Live. Shift to live case, please. Ma'am. To give a memento to Dr. Please, sir. Rajendra, are you able to hear us? Please. Here, sir. Kumar, sir.
What's the height?
Dr. Rajendra, are you able to hear us?
26, 28, sir?
26.
Yes, sir, we are able to hear.
No, maximum 24, 26 is common. Okay. Yeah, Ramaraju, I'm able to hear you.
Yeah, we are not able to see you. One still image we are seeing here.
Cameraman should focus on me.
Please.
You're able to see me now?
Not yet, but how far you have come?
We have done the punctures.
Yes.
Femoral punctures, not yet. Okay.
The punctures are done.
Okay, fine.
Focus hands
Can you
అంటే
keep-
ఇక్కడ చేయాలండి.
Can you keep timer? Yeah.
Monitor
Babu,
అంటే అక్కడికి వెళ్ళాలి.
it's your job to remind me every 3 minutes there. I will flush the femoral artery, okay? ఉంది already 1.2 minutes అయింది. Let it be there, 3 minutes. తెలుగు వస్తుందా లేదా? 3 నిమిషాలు నాకు గుర్చేయి. మళ్ళీ ఎందుకు బంద్ చేసావు? పెట్టు.
Every 3 minutes అమ్మా, re-timer.
Because live case కదా.
Aspirate flush కదా.
Good morning, sir. I request Dr. B. Srinivas, sir, head of the Department of TIMS, to moderate this session, sir. And I request Kumar, sir, also to join this session.
బాబు అది ప్రెజర్ ట్రేసింగ్ చేంజ్ చేయలేదు. చేంజ్ చేయండి ఇది.
FA రావట్లేదంటే
ఎఫ్ఏ వస్తుంది బట్ అది చాలా స్పీడ్ పెట్టారు. ఎంత స్కేల్ అది దట్ ఈస్ కరెక్ట్. అంత వద్దు
not that. దాంట్లో slow.
ఇంకా నార్మల్ స్పీడ్ పెట్టు. వాట్ ఈస్ ద స్పీడ్ నౌ?
25, 50.
Here, Dr. Kumar and Dr. B. Srinivas from NIMS, they are the moderating the session.
హాయ్ శ్రీనివాస్.
Hi Rajendra,
హాయ్ హాయ్.
it's very nice to see you and Vasant
యా
as a team there, and with me our dear friend Markandeya Kumar also is there.
హాయ్ కుమార్.
Hi Rajendra.
I think somebody wants to present the clinical case.
Yes, sir. I am ready with the clinical
Yeah,
details.
please go ahead. Lakshman, you present the clinical case. Before that, both of us went and examined the patient. Thanks Ramaraju to give a nice wall case. I think it's a very good pliable wall, and unlike the last case, it's not re-stenosis. So I'm happy it's a native wall. Clinically, there was a good opening snap,
Yes.
and his OS interval was narrow, and he has a very good mid-diastolic murmur with pre-systolic accentuation. And patient is in a sinus rhythm, and this is the clinical physical examination findings from me, and Lakshman can present the other data.
Sir, he is a 35-year-old gentleman presented with complaints of exertional breathlessness and palpitations in past 2 months, sir, without any comorbidities and no significant past history. Patient is in sinus rhythm with a heart rate of around 78 per minute, and patient is clinically stable. And this is our 2D echocardiography images. Left atrium is dilated around 5 centimeters, and the mitral valve area by planimetry is around 0.8 centimeters square. All leaflets are thickened.
Thermal 3
They are showing high gradients across the mitral valve with max gradient of 36 mm and
So,
mean
direct
gradient of
అదే ఇచ్చేది,
25 mm.
Direct 3.5 ఇచ్చేయి నాకు, అదే వైరస్.
This is the mitral valve movement in plaque view showing thickened and doming of AML with a restricted movement of PML with thickened AML leaflet tip, no significant MR.
మైల్డ్ అమ్మా. ఇట్స్ సెంట్రల్ జెల్.
బాగా యాంగ్షియస్ ఉన్నట్టున్నారు.
తగ్గిపోయిందిలే.
Left atrium is grossly dilated.
ఓకే. యువర్ డాగ్ అనస్థెటిస్ట్.
Tachycardia ఉంది. ఇక్కడ కూడా
అనస్థెటిస్ట్.
tachycardia.
What is this patient name?
ఓకే.
Patient name, Mitral years, 35 years male.
ఐ విల్ కీప్ 24.
T for some other case.
-2.
Mine rule is -2. Good wall -2.
So there seems to be some calcium on the leaflet there. What Rajendra, what is your?
Actually, the echo quality was not very good. It was very hazy here. I think you should be able to tell.
Sir, our recording was
Yeah, no, but I think Srinivas, what is your thing? Because it's getting transmitted from there to us here. I couldn't see the echo very good quality. So what do you think the wall score?
Yeah, so we are not seeing right now echo. We are seeing
No,
only
he
you.
presented the case, no?
No, sir, we are showing the echo images again, sir. Play.
3 minutes.
So there is a
Calcium is there only the tip, sir, AML tip.
no. Can you show the 4-chamber view?
Yes, sir.
Female MR is there, 1+.
Yeah, I see. Yeah, there is some nodule on the body of the leaflet there. But if commissures are free, I think you can still attempt.
But Srinivas, auscultation wise, it's a very good wall.
Yeah, you see the mobility, there is no question about that. You see, there is only calcium is very clearly seen, but I don't know whether it is related to the gain settings there.
I think the gain setting
Anybody?
is a problem. I think gain
Rajendra, 1 second.
Yeah.
Anybody, when they are doing an echo for the PBMVs, please always remember this thing. What is this? What is this? What is this? G? So this is harmonic imaging. Never do a harmonic imaging for a PBMV mitral valves. Whenever you do a imaging like that, that actually shows the mitral leaflets more thickened.
Yeah.
So you should have a regular normal. You should not have any rounds up on those 3 things. So you have to remove all those things when you are doing a 2D echo for any patients, specifically when you are assessing the mitral valve. Go ahead, Rajendra.
Gunavati. Kumar, it was done by Gunavati here. So Gunavati is here with
That
us.
G doesn't mean Gunavati. That is different assessment.
No, I told Gunavati next time don't record like this, okay?
No, people didn't think G means Gunavati, R means Ramaraju. That is the measurement.
Mark in Rajendra, mark in action.
Okay, now can you show we got both the punctures, femoral vein and artery. So can you see the fluoro images? Show the fluoro images. My practice is always to make sure that my puncture is on the femoral head. That's a very, very important step. Let it be a simple intervention, complex intervention. So I always make sure that what puncture I have done, I would like to see on the fluoro, it's on the femoral head, because patient should not go into pseudoaneurysm, or it should not go to retroperitoneal hematoma and all the possible complexes. Okay. So now I have taken the wire and I'm putting the wire into the. Can you see the fluoro?
Yes, we are able to see.
Okay. Can you see? Yeah. So that is the RA appendage, and now can you show that above, please?
What is this wire, Rajendra? This is O32 or O35?
O35.
O35
Okay.
compatible with
Compared to the Mullins sheath. So I am removing the sheath now. Innominate, sometimes it doesn't go. So what I do is I put a Mullins sheath and then manipulate into innominate.
Why should it go to innominate?
Yeah, because sometimes the manipulation take time. So I normally, many of the times it doesn't go. It's compatible or leda? It's very tight on there. No, it's not. No. It's not compatible. You use regularly thermo wire.
So why you cannot do a PBMV like keeping this wire in the SVC? Why you have to go into left innominate vein?
1 minute.
Just
Get
for
me
the
the sheath
sake of
again.
the
Get me the sheath.
listeners.
So it aligns well for the transeptal puncture.
Yeah.
The fall, the 3 falls, they say the classical falls. SVC to RA.
Can you
RA
show
to
that
aorta.
image once?
Pardon?
Can you show that fluoro image once?
What do you,
That wire.
No, I think they gave the wrong wire. So we're exchanging with the sheath
No,
again.
they have a fluoro loop of it. Yeah. See, when you come down like this, septum is somewhere here. Okay. So when you come from here, it will straight fall over the septum. So when you here and you're coming down, it will be difficult to align along the intrathecal septum. That's why you have to try to pass the wire into the left innominate vein.
Hey, thermo ichchara. Richi, thermo ichchara.
At this moment we are using 3-2.
Can you show the fluoro, please? Move the table.
Yeah, good.
That buckling of the wire in the RA usually happens when the LA is hugely dilated. What do you say, sir? Dash. It's a difficulty in going to the SVC or renominate.
Go to lateral view. Go to lateral view and pass it. Go to lateral view. Because LA is pulsed too much.
That gives an indirect clue that the LA is hugely dilated. In such situations, most of the times, whenever there is a difficulty in negotiating, we go to lateral view, take a RC catheter to redirect the wire more posteriorly, and it will easily go.
Can you hold the wire? I am putting the Mullen sheath now.
Yeah, go ahead, Rajendra.
Okay.
That's correct. But you may not go to innominator also. Without going innominator, you can puncture it. So it is not mandatory. It depends upon your learning curve. Yes.
So you should always aspirate this Mullen sheath well. Otherwise, if it's to the like, say I am not able to aspirate anything, there's a air in that. It's, now you should get a good amount of blood, and there should not be any air column inside in this, because once you put the needle, you'll be able to difficult to aspirate. So this is also important step. The other important thing is I have not put pigtail in the femoral artery because I am right now because I have not given heparin still now. So you can see the Mullen sheath. Dr. Dash has shown all these steps. It will be at 3. It will automatically rotate to 3 o'clock position once you go inside. And keep this Mullen sheath at the tip of this broken bone needle at the tip of the Mullen sheath.
Rajendra, for the people who came a little late, can you show what is meant by 3 o'clock position in that?
Yeah, can you show the camera here? So you can see this Mullen sheath at 3 o'clock position, and there should be gap between the sheath and the needle. That's very important. At least be 2 fingers. That's very, very important. Okay. Not pigtail now, no. So other important step is now aspirate this broken bone needle. That's a very important step, and you should aspirate very slowly, because otherwise the air bubbles will come and the whole system you have to do it again. So sometimes this can happen when the needle is against the wall.
Your 3-way, can you check your 3-way once?
Yeah. We are not used to this system. We always use manifold here also with an extension tube. So we are not used to this system of aspirating. Yeah. Okay, there is no air column here. So we have kept a timer here to make sure that arterial sheath doesn't clot. So we'll flush our arterial sheath again here because it is 3 meters over. Contrast. Yeah, actually what is recommended is to keep a different type of syringe. So we use a lever lock syringe for contrast. Anyhow, we'll go with a local practice. So make sure there is no air in the system, because once you puncture, your contrast is going into the LA. You're on the systemic side. So you have to be very, very careful. Make sure the whole thing is without any this thing. So now small amount of blood has come. I make sure I'm just checking the contrast. Make sure that everything is fine.
If you are not able to aspirate, you can little bit purge it. So little air go to SPC, nothing will happen.
Pardon, sir?
If you are not able to aspirate blood through that broken needle, you can pour some contrast, purge. So it will go air go to SPC.
Yeah, that's what I did now. Yeah. So now I am taking the pigtail.
Yeah.
And what I do, what I follow in my practice, which is taught by Dr. Padmanabhan, to keep the wire there, keep the wire, because I don't want to go to ascending aorta. What I do, I keep the pigtail here, remove the wire. I feel this is more safe. So what we are doing, we're in the artery, okay, and we're without heparin. So what I do, experienced operator like Dash might can do different way, but because here is a live case, I don't want to take any chance. So what I do is, can you connect? No, give just 3-way here. No. Pressure connect, pressure please. Yeah.
You want to put a continuous flush, huh?
No. What I do now, I am flushing pigtail below the diaphragm. So the advantage is if you have any clot or anything, you are safe still. So now my pigtail is flushed. Now what I do, I keep the pigtail in the aorta. So it's a small step, but just a little safety step. Because especially this is important for juniors who want to do this. Okay, now can you show the needle? No, yeah. So I shall take the needle as close to Mullin's and then start drawing. Come down. So my way of septal puncture is little different what Dr. Dash has shown. That's what how I was trained. Come down, please. Okay. Come down to lateral.
Rajendra, can you tell us, for the sake of juniors, how you are identifying fossa?
Three bumps there. One from SVC airway and second was aortic bump. And then I could feel the aortic pulsation there. So I stop it here and go to the lateral here now. And I do septal puncture in the lateral rather than RAO. I'm not like I've been trained like that and I'm more comfortable with that.
All those who are trained in NIMS are
trained that way. Any other way, sir?
You can LO view, RO view, depending upon the experience. Learning curve depends on learning curve. So I puncture here only frontal
so
view,
now,
not taking lateral view.
For the sake of the juniors,
now
I
I draw my Mullin's sheath more down.
Any tips for the puncturing in the frontal view, sir?
Frontal view, see that the Mullin's sheath should direct towards spine.
Where I'm trying to rotate the Mullin's sheath.
Posterior angulation may not be able to see in the fluoroscopy.
Sir,
frontal view.
Your vertical location, where how below it is from the pigtail.
So now I am in the mid position between the pigtail and spine.
But for posterior location,
and my Mullin's sheath is more at 4 o'clock to 6 o'clock position. Now I try to engage the sheath. Can you give contrast here now? Yeah. Open.
Dr. Rajendra.
1 minute. Yeah.
Can you just explain to all the beginners here as to how you select the precise location of the puncturing of the septum depending upon the septal anatomy? I mean to say between your pigtail catheter and the spine, where do you exactly select?
I always prefer midway between the pigtail and the spine. Okay.
Yeah, below the pigtail level.
Below the
See,
pigtail
if you
level
take arbitrarily, if you take a vertical line from the pigtail to the posterior aspect of the LV at the diaphragm level, almost fossa vallis will be at the junction of middle to lower 1/3. It's the most posterior structure. Fossa vallis is the most posterior structure. Whenever there is a huge LA dilatation or distorted anatomy, thus that anatomy will vary.
Wait. Yeah, I'm in LA. Can you show pressure? LA pressure now.
See, you can see
LA pressures, please.
You can see the direction of the bevel there. Bevel is.
Can you show LA pressure? It's not given. LA pressure. No, it's not coming.
Can you show the position of the puncture needle?
Yeah, puncture needle is facing almost 5 o'clock position here. Yeah.
Come to AP. Contrast. Come to AP.
Have you entered into left atrium?
Yeah, I have punctured, but somehow this contrast syringe, these people, they gave saline here. So, test please.
Are you getting the trace, Rajendra?
Test. No. Yeah, it's there. Give it, it's there. Okay.
Can you see the fluoro?
Can you keep MAC, please? MAC. Test.
It's a low puncture. You entered LA.
So what I do is, I enter with the needle in LA. Small test, please. Contrast. So identify the roof of LA. So then what I do, I fix my needle and go with the dilator and Mullin's sheath here. So this is where you have to be very, very careful. Okay, test. Okay, now what I'll do, I have gone up to dilator. So now you should not push the dilator. Some test again, please. Good test. Yeah, that's the roof. So I have identified the roof. So now I keep the dilator and thread my sheath on this. So here what happens, especially with the G Mullin sheath, which is a common practice in our country, the dilator jumps and touches the roofs of LA. So you have to be very, very slow and gentle here.
Introducer, yes.
It's not in LA, no? His pressure is also not coming. Why pressure is not coming?
Understand? Yeah? This is for EP study. This is for if you have taken the catheter.
So you keep the dilator also within the sheath?
No. We usually we remove and keep the sheath
the
itself.
sheath only.
What Professor Dash says, instead of removing the dilator, instead you can keep the LA wire directly through the
That also
sheath and introducer.
I think I am not comfortable with this position. I have to redo the whole step, correct?
It looks like quite a low puncture.
You think it's a low puncture? You think I am in LA? No,
Yeah,
pressure.
you are in LA.
The
You're in
problem
LA.
is I am not getting pressure. Please do something. Get me pressure of LA. Go to 20 scale and show me LA pressure, please.
Second pressure.
What about femoral pressures?
Femur I am just aspirating.
Okay, fine.
Rajendra, you can go to the lateral view and see whether the catheter is crossed.
Go to lateral.
No, it's crossed. It's in LA. It definitely.
You can
it's
see the echo also. You can see the echo, Rajendra.
Go to lateral, please.
Why he? No, he removed the pigtail catheter, sir.
No, why
He removed
this
the pigtail
LA
catheter.
pressure is not coming? Wait, Pani, can you just check why LA pressure is not coming?
Yeah. Yes.
ఏ స్కేల్లో ఉందో తెలియాలి ఫస్ట్
Yes. We keep the wire.
Yeah.
Okay. That's a different story. What he is telling is, they will not remove dilator. They will pass a LA wire through the dilator instead of removing it, pushing the sheath and keeping there. They keep the entire unit in toto in the LA and push the LA wire through that. It gives a more secure.
So we got back our arterial pressure, but LA pressure is still not seen. LA lo undamma Mullin sheath.
Can you pull that
Can you
thing a little
Go
bit?
to lateral, please.
out?
lateral Rama.
Lateral.
So what about echo? Can you see the sheath crossing?
Sheath కనబడుతుందా LA లో ఉందా? I want to make sure that.
No, ఇక్కడే చేసేద్దాం.
No, pressure is more important, boss. We are dilating next step.
Yes.
But why pressures are not coming? Funny, can you just dewash?
తీసుకో ఈ లైన్ తీసుకో ఎఫ్ఏ లైన్ ఇచ్చేసే దీనికి విల్ ఐ డోంట్ నో టిల్ వి సార్ట్ ఇట్ అవుట్
Yes, sir.
Can you pull back that catheter a little bit out, Rajendra? Can you pull back it?
Anyhow, I think we are in LA. What we'll do? We'll remove fluoro, please.
No, just pull it back a little bit. Now you see. Just pull it back a little bit. Now you see. Probably
No,
you are
it's not
touching the
coming.
LA wall.
It's not coming. Okay, anyhow, come to AP. Come to AP, please.
If you are not comfortable, go for a fresh puncture.
No, let's see how it behaves. Come to AP. Middle, please. Okay, I'm removing my. Give me the LA wire.
Transeptal puncture I had talked.
Yeah, I think the blood is LA blood. Okay, I can see that. Can you show the blood here?
Yeah.
Okay, so I'm in LA only.
Most possible reason could be that it is touching the LA wall.
సెప్టల్ డైలటేషన్ తర్వాతే we do like that.
I think in Nizam's days, when while doing transeptal puncture by Professor Jaishankar, they used to do it with a pressure tracing mode. He used to be in SVC RA. There used to be pressure damping whenever.
Okay.
Are you doing like
So
that, sir?
my other important thing, what I do differently is I don't give heparin. Okay, until I do the septum. Srinivas, same thing.
I totally agree with you.
Yeah. So
I think it is at this juncture you can order for heparin.
So I will not order till I dilate my septum. Okay, so That's what how I practice. Can you give the pressure tracing to femoral artery here? Can you connect? Vasant, can you connect the femoral artery tracing here?
The septal puncture location between a straight intraatrial septum where there is no very high LA pressure compared to bulging septum into the RA is in a mitral stenosis for PBMV is different. While you try to enter into the left atrium through the fossa vagallis in a septal puncture for any other indication, you would like to go a little more inferiorly for PBMV. That's what Rajendra has done there.
So I am taking the dilator now, and we have to dilate the groin. You should make sure that it goes well. So there is another step here. Okay. So now once I am in the dilator, so I push the dilator and it's removed by my second operator. Just remove the dilator by maintenance. Yeah, that's very important step. So then I push it inside, he withdraws it again. Can you see the fluoro, no?
Yeah, we are able to see.
Okay, so I push it. My operator Vasant is doing it again. So I push it. So other step what I do differently, this is what Padmanabhan always teaches. So you keep the dilator across the septum. So it will dilate more. And now I give heparin. Can you give heparin 5000 units now? So this is little different way. Each person got trained in a different way. So this always we try in our lab. Can you give heparin 5000? Yeah. Across the septum. So this is how I practice, because you'll get a little more stretch. So balloon might cross easily. Because we all work with G balloons. Second, the wire is not going above the bronchus. Okay, that's how you're still in the left atrium. That's also important. That relation always used to make out. So I'm comfortable with the dilatation. I'm happy. I'm removing my dilator. The another important next thing is dilatation of the groin. That's also very, very important step. Okay, so the second operator maintains the wire. I dilate the groin. Again he removes the dilator and he maintains the wire. Again I dilate the groin. He removes the dilator. Okay. Yeah. So this is additional, this is how we are trained. And most of PBMVs I learned from my teacher, Dr. Padmanabhan. So the balloon we have taken is 24, 26, and I am going to do -2. That's always, any case I will do -2. Let it be any type of wall, it will be 8 or 6. I don't do more than -2. That's how I practice, and I have done only 200 cases. This is my little experience. And the other important step is the crossing of the balloon with the groin. Can you show here? So what always my mentor used to say, when enter you should go more vertical, and then you have to use brutal force. This is called brutal force. So and then we enter the groin. Okay, that's a one first resistance where you get it. So now after this,
there is a very important point, Rajendra. Entering the groin with the balloon, you should never twist the balloon when you are trying to.
I never twisted. So that's why I told push
no rotation
with a brutal force. That's the use. So nothing to worry. So now once, here is the one step where Dr. Dash has also shown, you have to cross the septum. So you have to little adjust and cross into.
Yeah. Yeah, the balloon is unlocked. Yeah.
Okay. Yeah.
Balloon is unlocked.
Yes.
I think it's crossed.
Now,
no, not yet.
Now I cross septum with little manipulation. Now I'm on LA. Now first remove the yellow neck.
You have not crossed the septum totally.
Pardon?
You have not crossed the septum totally. So fluoro?
Yeah, I'm on fluoro now.
No, fluoro.
I'm on fluoro. Can you show
Balloon not
fluoro,
gone
please?
totally.
Can you show
Balloon not
fluoro?
gone totally. Balloon not gone totally. I gone it?
Now gone. Yeah.
So other important thing, when you do decentralize, make sure you log this again. Otherwise, what has happened? Why this contrast has come?
No. Person not good. Puncture not good. See, useless wire.
ఏమైంది?
So this is a very crucial step.
Balloon fully should cross the septum.
This is the period where you will have lot of chances of cardiac tamponade. So you have to be very careful when you are manipulating the balloon. See that it should not hit the left atrial wall.
ఫస్ట్ ఇదే తీయాలి కదా, గోల్డే కదా.
Rajendra, I advise you to remove that stretching rod and holding the stretching rod firmly over the telescope the balloon into the LA. That will go atraumatically and with the shape of the LA it will go into the in a curved fashion.
But I am
Yes,
worried why
Kumar has
this
said it
contrast
will,
has come.
just like that.
Why this contrast has come? That's what my worry. What
I will never enter into the LA with the stretching rod inside. For this reason, for what Kumar has said, it might cause cardiac tamponade by rupturing the LA free wall. And one more reason, when balloon is very stiff with the stretching rod inside, it is likely to cause an acute angled kind of distortion or kinking on the LA wire that will complicate the procedure later.
This LA perforation usually happens when pre-dilatation of the septum is not done properly. Suppose balloon jerks into the LA, most of the times this happens.
Yes, Ramaraju said it's extremely important to dilate the septum.
Yeah, it's very, very important.
That's one reason what he has said. The other reason is for you to have proper
Can you show the LA pressures
of the balloon for crossing the LV.
Okay.
Septal dilatation is very important.
Okay. Can you give me pictorial now?
40, 22.
Mean 22, huh?
Can you give flush? Can you give flush? No. Can you take the syringes out here? So what I do, always we check the hemodynamics. Wire bitledu, wire. Push it.
Do you always keep pigtail in the LV while crossing, sir?
Lab.
Pigtail as a reference. You don't take a femoral.
No, I will not do pigtail while crossing. Okay, I always remove
aortic
pigtail.
position, sir. Rajendra, it's a great experience from Dr. Dash. He never does an arterial puncture, it seems.
I know. He told me that.
Yeah,
that is only for demo case. He showed arterial puncture. He never does it.
It's a wonderful.
Person can do that.
Being a workshop, I thought always to show hemodynamics, the gradients, everything. I always prefer to do that.
No, otherwise nobody measures LV pressure routine AS.
Try a puncture and it's not a proper puncture, you would like to redo. But your pigtail is already in the LV. I wouldn't, and crossing the LV would be if there's some difficulty or some mild AS is there. I wouldn't take a chance of using the pigtail.
Both 40 scale over that.
Okay.
50, 60 scale or something like that.
Why that? Why
Yes,
that?
we see the problem is not the matter of crossing the mitral valve with the balloon. It is the marker while doing a septal
Why
puncture,
this
transeptal
tracing
puncture.
is not coming well? Pigtail. No, pigtail tracing. Can I flush outside, please? No, I'll flush outside. There's some
While
air
doing
here.
transeptal puncture, pigtail.
Open.
Yes.
Open. This is not the one. Yeah.
Okay.
Can you zero it again?
Yes. Now it's coming.
Can you zero? No. Shall I flush this? LA also, please. Okay. Flushing. Okay. Now, make it both zero and show the tracing. Can you go to 40 scale? Can you go 40 scale, please?
So whenever you're doing a PBMV, the venous axis should
Yeah.
be 8 French
Yeah.
and arterial axis should be 5 French.
They remove that blue
So
tracing. No, what is
you
the
can
blue
take
tracing?
a 5 French
SpO2 tracing, remove
so
it
that
please.
the chances of having
Remove the
arterial
SpO2
bleeding will be
tracing.
less.
Yeah, yeah.
This is the common
Now you can
practice
see
what
there's
we
a
are
very
doing.
nice gradient. LVDP is around, this is 20 scale, LVDP is around 10 and this is about 27. So there's a good gradient in the mitral wall, and always I like to see this gradient before I dilate. So now I remove the pigtail and I keep in the descending height again. So Ramaraju, what do you think why the balloon is deformed like that?
It's a low puncture.
No, I'm telling.
Here, okay.
No, shape,
can
not even
aspirate
shape.
the balloon- the
There is
balloon
something
is
in
filled with some
the,
air.
there is something, I think there is a air, I think the balloon is not
Yeah,
prepared
you
well.
have to aspirate the balloon.
I think you have to aspirate the balloon, there is some air.
Give a negative
Can you do
pressure
that?
into the balloon. And
Prepare the balloon well again, before that, before I go there.
pull back the. Yeah.
There is air, see, there is a lot of air.
Because of air, it is like that.
Yeah, that movement you can show it to the juniors. Sir. That movement indicates that the tip of the balloon is in the pulmonary vein.
Yes.
It's not in the mitral.
Yeah, can you do it again? Yeah, can you de-air the balloon, please, de-air the balloon.
Fresh syringe to aspiration.
Fresh in the aspirate, just de-air cheyama, paraledu. How
Same,
did air
same,
go
same.
inside, I didn't understand. Chay, you can do it, no problem.
We do it as Kumar said, we do it with one with the 5 French catheter. 5 French sheet. Yeah.
Okay.
Yeah,
Yes, sir.
no, still lot of air is there in the balloon. Etla sakka in the balloon?
Over there in the cath lab, each and every fluoro kindly make a save of it so that they can be replay it. Any points to be informed, we can inform here.
So what we are doing, we are de-airing the balloon. We have
I am
kept
informed that the cath lab technicians to do a fluoro save
still there, see?
for each and
Still,
everything.
you can see here.
Hitting the wall there or the connections are loose. It's hitting the wall there.
Correct volume same 24.
No. Anyway, he is not inflating that.
No, there is air. We are removing the air in the balloon. Okay. So I am putting the LA stillet. Babu, correct on that 24? Shall I wait?
That balloon should have more negative pressure, Rajendra. It's still.
That's what I have to do.
Till it's not deflated.
He is doing it. 24 ఉంది కదా.
See, this is the
Deflates
thing
a balloon
what you have
deflates
to see, that balloon should not have that this
Yes.
appearance. It's supposed to.
Yes.
There should be something like a
I
gap
still
between.
don't know why.
Can you show that fluoro? Can you show that fluoro once?
Why? There's something wrong.
Yeah. See, you should not see anything in between.
There's something wrong with the balloon. Something has
If it
happened.
happens, means there is some contrast.
Sir, Dash sir,
in it
what do you
or,
think? What is the
there is
diagnostic? Why this amount of, what is that in the balloon?
Balloon actually you have not prepared well because you have not, when you dilated the balloon diameter, you didn't push the diluted contrast and not aspirated. Then not done. Now okay, fine. There is no air. Okay, fine. Go ahead.
But I am not able to push.
Cannot because your puncture is low puncture and there is septal catch. Now go to RO view. No, you do
Areo.
You are in RO now? The frontal, this is frontal, 90. RO, yeah. Counterclockwise the stylet.
This is the exact role of TEE, intraatrial septal.
Counterclockwise stylet, counterclockwise and remove the stylet and fluoro.
Where am I and fluoro?
No, we can't see your fluoro.
Please show the fluoro, please. Don't show the hands now.
Yeah. So, no, make counterclockwise stylet, little pull the stylet and push the balloon. Yes. So, it won't go like that. So, what you could do, you can give a shape to the stylet, little bit.
Pardon?
You have to give shape to the stylet, reshape the stylet. Because your puncture site and the mitral valve area is very small, so you have to, very difficult to move the balloon.
Even that balloon also has to be kept in negative, constant negative pressure. Somebody
He's doing constant negative is doing.
Padmanabhan, what is your opinion about this particular position of the balloon and what would you do in this situation? I want Padmanabhan's comment. No, are you happy with the position of the balloon here, please?
No.
Do you think septal dilatation?
No, not septal dilatation. Is as Dr. Dash said, we have to change in the stellate shape. Will be.
I think this with this
You have to make it more shallow. You have to make the stellate more shallow.
The septal puncture is very low. So because the gap between septal puncture and mitral valve is very small, the balloon cannot be. You can't negotiate.
Yeah, routine counterclockwise torquing might not
Help it
you into the left ventricle. And
So you are going to
you will need a reverse loop here or
Yeah, two ways. Yeah, hairpin
So what
or
is the
making
suggestion?
the
What is the
stellate
suggestion?
less shallow or take an alternate loop.
Shape of the
We demonstrate a case of alternate loop tomorrow.
ఇంకా తగ్గిపోతున్నాడా?
he wants to make it shallow.
షాలో కదా, ఇదే కదా, మోర్.
Partially inflate the distal balloon and try pushing to that, sir.
Negative.
So second operator should focus on the balloon always. See, there is always some contrast in that balloon.
Yeah, that's what
There should
from the
not be any
beginning I think they
contrast
have
like
not
that.
prepared the balloon well.
Yes, no, sir. Let them try, sir. Let them try, sir. Inauguration session is there.
What is the LA size in this patient, Lakshman?
LA size, I think it's a 5.5 centimeters.
So whenever the LA size is above 5, the successful PBMV rate will come down. In this is the cases where you have to take more of alternate approach rather than direct approach. So that LA size measurement is one important predictor whether PBMV is successful or not. That's why I asked about the LA size.
Will you go there, sir? Sure.
I think you have to do alternate loop for this patient because the septal puncture is low. What's inverse?
Take the reverse loop and put more balloon into the left atrium. I think you have to again put the LA wire over that, put a lot more balloon into the left atrium. It's a huge left atrium, as Kumar said. And this much,
But I'm not happy with the balloon itself. I don't know why there's a lot of air in the seal balloon.
Okay.
Actually, I should have supervised. Ramaraju, Ramanu. Tell Ramaraju to come to cath lab.
Rajendra, there will be inauguration program now.
Okay.
So you continue and please record the essential steps and
we'll complete in 5 to 10 minutes.
We will come back to you again.
Okay.
Thank you.
Saline better. Give me that LA jalebi bar. I don't know why. LA jalebi bar. జిలేబీ పెడితే బలూన్ మళ్ళీ ప్రిపేర్ చేసి చెప్తా వైరెళ్ళు ఓకే వదిలే ఓకే తీసుకో బలూన్ తీసుకో రిమూవ్ ద బలూన్
So just now,
బలూన్ చూడమని చెక్ చేయి ఒకసారి ఏమైందని మళ్ళీ ప్రిపేర్ చేయ బలూన్ని
in the mid of the scientific program. Now we will move to the inauguration session. I request Dr. Grandi Bhaskara Garu, Chairman, GSL Group of Hospitals, to kindly come on to the dais, sir. Next, I request Dr. Gudur Srinivas, sir, Professor and Chief Consultant Pulmonologist and Observer for our today's scientific session, to please kindly come to the dais. Next, I request Dr. Guru Prasad, sir, President, IMA Rajahmundry, to please join us. Next, I request Dr. Vijay Bhaskar, sir, Secretary, Indian Medical Association, to please kindly come on to the dais, sir. Next, I request Dr. TNC Padmanabhan, sir, our mentor and teacher and our founder of this PBMV program in KIMS, to please join, sir. Sir, now I request Dr. Grandi Bhaskara, sir, to please kindly address the gatherings. I request our CEO and head of Dr. Ramaraju, sir, to please kindly join.
Thank you, Dr. Grandi Bhaskar, sir, for accepting and sparing your time. Volume, music volume. Decent. For sparing your time, because we know the value of your time. You kindly accepted to be here for this, and we made you to sit for a long time here, and thank you for accepting this. And I thank Dr. Gudur Srinivas Garu. We know you are a very busy practitioner, and this happens to be a working day, and you are an observer for this session here, and thanks for being here to be as an observer. And I thank Dr. Guru Prasad Garu, Chairman, President, Indian Medical Association Rajahmundry, and Dr. Vijay Bhaskar, Secretary, Indian Medical Association, and Dr. Padmanabhan, who is my teacher and who taught us how to do mitral valvuloplasties. Basically, majority of the operators nowadays, now in the present session, are trained through Dr. Padmanabhan. And I request Dr. Grandi Bhaskara to light the lamp and start. Sir, we organized this hands-on workshop for mitral valvuloplasties because young generations are not getting an adequate opportunity to do the procedures because the cases are coming down, and only, I don't know what is the reason, the East Godavari district will be having a huge number of mitral diseases. Please, sir. I request Dr. Grandi Bhaskara to say a few words about the workshop.
Respected dignitaries in the S, the Padmanabhan Garu and Ramaraju and Guru Srinivas and Guru Prasad and Vijay Bhaskar and the cardiologist, enthusiast cardiologists come all the Andhra Pradesh and to visit the actual workshop in the PBMV. I think the interventional things, see, the way back about 98, when you want to start a cath lab in Rajahmundry, we had a meeting about all the cardiologists and to sit together to want to get. the people, the stalwarts of the cardiology people came to Rajahmundry, they discouraged us. They discussed because it's very tough job to make a cath lab, too much costly, a lot of things. But we said no. But each center should develop. Each place of Andhra Pradesh should develop, not like a Hyderabad and not like just only because Andhra Pradesh from Telangana to, from Nellore to Srikakulam, and lot of centers are developed previously and also now also developing. At the time we made a head and got it done. Now almost about 10 to 12 cath labs in Rajahmundry. 12 cath labs. That is the things of Rajahmundry. It is never competitive world in Rajahmundry at all, and we are Akshaya Patra Rajahmundry. ఎంతమంది వచ్చినా తీసుకుంటుంది, ఎంతమంది వచ్చినా పేషెంట్లు ఇస్తాయి. అందువల్ల quite ethical practice what they are doing in Rajahmundry and quite encourageable one. I think the interventions what they are doing now, just now in our hospital they are doing the robotic training program. The pupil has come from the cadaveric training from the Bangalore and other places. They make a training. Like Rajahmundry is a center of excellence in all the specialties, including the robotic surgery, cardiology, and all other specialties, also gastroenterology, everything. I think God bless you, Ramaraju. Thank you.
I request President IMA Guru Prasad garu.
Thanks, Ramaraju, for giving this opportunity. It's a wonderful program going on here. I wish all the best to the delegates.
Thank you. I am Secretary IMA, Dr. Pidugu. యూజువల్గా ఒక హాస్పిటల్ కానీ ఒక డాక్టర్ గారు కానీ ప్రతిరోజు నేర్చుకుంటూ ఉంటేనే తప్ప ఇంకొకరికి టీచ్ చేయడానికి అవకాశం లేదు. అటువంటి గొప్ప కార్డియాలజిస్ట్ మా రాజమండ్రిలో ఉన్నందుకు మేము గర్వపడుతున్నాం. దట్ ఈజ్ రామరాజు గారు. ప్రతిరోజు నేర్చుకుంటూనే ఉంటాడు. నిత్య విద్యార్థి అయినందువల్లే ఇంత ఉన్నత స్థాయి అండ్ అంత గొప్ప టీచర్స్ ఉన్నారు కాబట్టి ఈయన ఈ స్టేజ్లో ఉన్నందుకు మాకు గర్వంగా ఉంది. ఆయన అకాడమిక్గానే కాదు, ఈవెన్ కల్చరల్ యాక్టివిటీస్లో కూడా చాలా యాక్టివ్గా ఉంటారు. డ్యాన్స్లు వేస్తారు, పాటలు పాడతారు. ఈజ్ అదే ఎన్సైక్లోపీడియా లాగా. వన్ వర్డ్ టు సే థ్యాంక్ యూ వెరీ మచ్ గివింగ్ మీ దిస్ ఆపర్చునిటీ.
I request Dr. Satish sir, Superintendent and Chief Cardiac Surgeon, to please kindly join us on the stage.
I request Gudur Srinivas garu. I request Gudur Srinivas garu say a few words, please.
Good afternoon to all. Greetings from the AP Medical Council. I congratulate Dr. Ramaraju and his team for conducting this wonderful workshop. Hope you are enjoying this academic feast. God bless you. Thank you.
I request Dr. Padmanabhan sir to say.
I thank Dr. Ramaraju for inviting me here. Actually, when I look back and see, the whole thing started when Dr. Ramaraju came and met me in my house. That was the time he took a decision to move to Rajahmundry and start. And it was the first cath lab those days. So there were no interventional cardiologists in Rajahmundry. He took that bold step of coming here, starting in a center that is city hospitals, where there was absolutely no infrastructure. Everything he had to start from scratch. And because of his drive and enthusiasm, he could reach, and he could make this one of the best centers in this combined districts of Godavaris. And not only that, he is one of the leading hospitals in the entire Andhra Pradesh nowadays. He is a very nice person, always smiling, very hardworking, and keeps a very low profile. That's the best part of Dr. Ramaraju. Thank you.
Thank you for a kind word, sir. And with your blessings, actually, we are now one of the highest turnover cardiac procedures and cardiac surgery and cath lab procedures in the entire state of AP. And I request Dr. Satish.
Good afternoon, everyone. Because I'm a host, I welcome you all to this wonderful session. As I'm a surgeon, probably I may not like this kind of workshop, but just now Dr. Gani Bhaskar sir was telling only 40% of the cases you do and 60 I do. Anyway, here on an average cath lab turnover per year is around 6,000 procedures a year, and we do around 1,000 cardiac surgeries a year in this small place. Small place means Rajahmundry, what I'm comparing with Vijayawada, Vizag or Hyderabad, Bangalore, like that. And Dr. Ramaraju, you all know, he is working for last 25 years in this place, and me around 20 years. And we have plenty of cases, as you all watching since morning. We have variety of cases, and anytime on the behalf of Dr. Ramaraju Garu, I welcome you. Even after workshop, you people can come and observe, do some cases when there is opportunity to do PBMVs, because this is one basic procedure which people are forgotten. Just now, the Padmanabhan sir was also telling, we forgot how to do CMV. So there was a workshop in Washim in Maharashtra. I went from Hyderabad to Washim to do 2 CMVs because we have never seen closed mitral valvotomies. So like that, PBMV also may go over a period of time because endemicity of the rheumatic heart disease is coming down. But better you people learn early so that you can do infrequently when there is an opportunity in your setup. And I welcome you all again. Thank you very much.
Thank you, sir. As a morning I spoke, the mitral valvuloplasties are becoming a rare disease, a rare procedures nowadays. Many of the beginners are not getting an opportunity to visualize it. In earlier days, when we are trained in Nijams, our Professor Jayashankar used to do pacemakers. At those days, only Professor Jayashankar used to do pacemakers. And hardly we used to get an opportunity to witness a pacemaker, because he never used to allow a person to enter into the pacemaker lab, because that much sterile techniques he used to adopt, and we used to pass out of the DM without witnessing a pacemaker. Many of the DM residents, that much forgettable doing. See, that much schedule he used to maintain. Similarly, nowadays for the PBMVs, many of the centers are not doing. One is lack of expertise, and second thing is majority of it is covered in Arogysri, very poor package, and many of the cardiologists are refusing to take a chance of doing a PBM at a very low cost. So whatever may be the reason, the PBMs, the number has come down significantly, but never our management objected. Dr. Bollan Bhaskar never objected. And we always keep doing the cases. The PBMs from the last 20 years, even after the Arogysri also, we are continuing to do PBMs. So our turnover will be on average of 10 to 12 PBMs per month. We will be doing in regular batches like that. So of late, after the COVID, there was some scarcity of the hardware. So from the last 2 months, we are not able to do a single case because the cases were not, hardware is not available. So it led to the pooling of cases. We got some 60 cases as a pooled when we stopped doing from the last 3 months. So me and my colleague Lakshman said, "Sir, why don't you conduct a camp?" So immediately we took a decision, asked my seniors, and immediately they accepted. Without any hesitation, they accepted. It's very difficult to get a time for them to be present here. But somehow, once we called them, immediately they accepted. So all of a sudden, in a 15 days time, we arrange this program. And initially, to get a CME credit hours also, they take minimum 2 hours of prior intimation to get a CME credit hours. But my friend Dr. Gudu Srinivas, who happens to be AP Medical Council member, he somehow recommended and influenced register to get a credit hours also for this session at a very short notice. So definitely I think, and another development is, I never thought 3D EQ will be of use for this session. My friend Kumar, he said 3D EQ should be there because we are not tuned and handling the 3D EQ. So immediately asked the Philips people to organize the mission. So they arranged 3D EQ here. From the last, the enthusiasm that Kumar has is, he came yesterday night itself to learn and do the PBMVs on mitral cases, and morning he recorded cases and he started preparing for it. I really appreciate the enthusiasm he has in performing echocardiograms and learning new skills and to deliver the same knowledge to the juniors. Really appreciable. And with his support, we kept a 3D commission here. It is available, and if anyone is interested to learn, T application manager is there. He will be available today and tomorrow. You can go and learn in the ground floor eco room. And we arranged one more hardware training session for those people who want to learn how to handle hardware. We arranged a session in the 4th floor. Professor Dash will be there, and my colleague Dr. Sivaprasad will be there. He will be able to tell you how to handle the Mullin sheath, like introducer, broken pro needle, how to inflate or deflate the balloon, etc. So I think this session, these 2 days session, will bring confidence in you performing the mitral valvuloplasties on your own. Thank you.
Okay, in the previous live case too, we have a trouble. Now, again, our live operators will discuss about the troubleshooting, what the problem we have faced and how did we rectify. Now, again, I request to go to live. And small announcements, we have 2 demo rooms in 4th floor. One is for hardware, PBMV hardware, and other is for 3D echo hands-on training by Dr. Kumar sir. Okay. Both the rooms will be open from 2 o'clock. 2 to 4 we have the both demo rooms. Thank you.
I have show man here. I don't want to listen to you. Show FA pressure here.
Accept it, sir. You
No, sir. I just want to make sure the FA pressure.
No.
Tracing.
No, LA 16 now.
Yeah. Adi 40 scale better change LA ne, or 200 scale better change LA. Come down.
Good, very good result. You can't ignore. No? What do you say?
Okay. Shall you go to pigtail and measure the gradient?
Take the wire, sir. It may not go.
नहीं थोड़ा सप्पल हो
गया यूज नो ऑलवेज टेक वेयर अदर
या इचे मा वायर ये मा पिगटेल वायर
yeah, them just LA is now 10 12
no they not come live still
Jain sir, sir, am I audible to you, sir?
Yeah, you're audible to me.
Now LA is
yeah, Rajendra.
LA mean?
Rajendra.
Yeah, we are there. We have finished
So
2 dilatations in the meantime.
Tell us what has happened during our inauguration program. What went over?
Kumar, you are not audible.
Am I audible now?
Now you are audible. Yes.
Yeah. Just the inauguration program has just concluded. We just wanted to know what has happened in this meantime.
Okay.
We shift a little bit of.
Can you show the 40 scale? 40 scale now. Can you show 40 scale both pressures? Are you able to see the pressure tracing now?
No. Ask them to show fluoro.
No. Now let's start from retrograde. Okay. Let's come backwards what we have done. See the pressures now.
Pressures not coming.
Can you show the pressures? Monitor please. Are you able to see?
No, sir.
Can you show the monitor please?
Yeah. Go ahead.
Monitor?
Yeah, we are able to see.
Monitor? Kumar, are you able to see?
Yeah.
Okay, now if you see LA pressure is 17. Okay,
Yeah, with 100 to 110.
110. So we had starting LA pressure of 38 and 22, mean of 27.
Okay.
So can you go back now all the steps? Can you go back fluoros wise 1 minute? I'll remove this. No, I'll remove this pigtail. I don't want to keep any pigtail. Can you go back on fluoro images? Yeah. Can you play this? Can you play this please? Somebody up from the fluoro. Flush.
No.
Cine loops amma. లాస్ట్ నుంచి రమ్మా చెప్పింది. ఓకే, నౌ డూ ఇట్. ఓకే, కెన్ యూ ప్లే దిస్? No, play that piece, the balloon one. The balloon please. The inflated balloon. Okay, long shoot. Yeah. Okay. So this is the second time we crossed. Okay. Now we inflated the distal balloon and locked it and made sure that everything is free. It's not in the chordae or subvalvular. And this is the second inflation we did. And the second inflation we gave higher pressure, higher volume. That was 24 and this was 25. And after this we got further reduction in LA pressure. So from first we had mean of 27, it dropped to 20 and now it's mean of 16. I think we don't want to go more than this. This is a good result. But only thing is still I am not understanding why there is a contrast leak in the balloon. So I don't know why this is still there. So go back again. Go back one more step. Go back. The first balloon inflation. This is the first balloon inflation. Can you go back one? Can you show this inflation?
No, how could you cross this metal wall?
Pardon?
Did you do any alternate approach or?
No, it's the same. No, direct same. No alternate approach.
So what modification you did?
What doctor? See, there was change in the shape of the stellate. Can you show that, sir? This one.
Okay.
This is the one.
So you made it
Can you
much
show the
more wider
pictures,
angle?
please, here? Can you show the hands?
Just get it to bed, give tip. Like.
So can you show the pictures again? Can you show the first inflation? This is the first inflation. So this is the apex. Making sure it's not entangled here. Make sure the balloon is free. And then this is the first inflation. This is what we got.
The result very good.
I think the result is good. I think we'll remove the whole system now.
Rajendra, can you show that image of inflation of the first balloon?
Kumar, you are not audible again.
Am I audible now?
Yeah, now.
Can you show that fluoro image where the first balloon is inflated and you freeze there?
I'm just destabilizing the balloon. I'm removing the balloon. I don't want to keep it for a long time.
Go ahead.
Can you push the spring wire in LA? So this is important. When you remove the balloon, the spring wire has to be in LA, okay? And then you stretch the rod and then you pull the and lock it. This is how you decentralize.
Dr. Dash, can you tell us how to handle this low puncture site? Any
Now
tips and
I am
tricks?
removing the whole system with the spring wire. Yeah, sir.
Somebody has to.
Can you inflate that balloon outside? See what has happened to the balloon.
No,
once,
no
Rajendra?
problem, sir. That's not a problem. I'll hold it. Don't worry. I'll hold, sir. Don't worry.
Dr. Rajendra.
Not flush. Flush చేస్తున్నాం.
Stop.
Wait.
Usually what we give a figure of 8 stitch. Butterfly.
So Kumar,
Yeah, go ahead.
There were two problems in this case. Okay, it was a low puncture, and then we had difficulty in crossing.
Your voice is not clear, Rajendra.
Yeah, here.
Mic is here.
Mic.
Okay, now we had two problems. The first one was it was a low puncture. Second, the balloon, there was some air and contrast in the balloon. So after we went off live, what we did is we removed the balloon from the system on the spring wire, and then we rechecked the balloon. Is there any leak in the balloon? There was no leak in the balloon. We rechecked, and when again we checked for a 24, and then we threaded the balloon. But still there was some contrast in the balloon. I don't know why there was a contrast in the balloon. Even after keeping the balloon in negative, we went there was still contrast in the balloon. We don't know why it has happened. Then because by changing the shape of the LA wire, we could cross the balloon and inflate it. The first inflation, there was 10 millimeters drop in the LA pressure. We thought we have to increase. We gave 1 more ml and then did a second inflation. That's what the second inflation showed. Before second inflation, we checked the echocardiogram. There was no MR. So that's why we went with the second inflation. And now we are having a 4 to 5 millimeters gradient across the mitral wall, and we're happy with this. But still I don't understand why the balloon behaved like that. It can't be because of low septal puncture. The balloon, there was contrast in the balloon. Even after the second preparation, there was a contrast in the balloon. Dr. Dash chale gaye. Dr. Dash has gone. So I think we should go for the second whatever the program there. I will sign off if you say yes.
Okay, did Dr. Dash has any comment regarding the balloon contrast retainment?
He has come, I think, on the floor. I think in the.
Okay, if case is complete, you can join for lunch, Rajendra and
Yeah.
team. Please.
Good job. Good job.
Good job. Congratulations. A small working lunch, and 2 sessions will be there available. One is a hardware training and one is a 3D imaging. If anyone is interested, can go there and join. And post lunch there will be a beautiful talk by Dr. Dash. His experience in PBMV, he has a wide collection of cases, and please don't miss that.